member health of Niti Aayog. I'm sure the audience already knows, but just emphasizing that. And Dr. Dang, could you speak up a little? Your voice is a little soft. I know you're soft-hearted, but you'll have to speak a little louder.
Yes, sorry, am I better now?
Yes, thank you.
Okay. So, taking the clue from what happened in China, and then as it spread to Italy, and the first case which came to India and Kerala, we all were taken aback that now it is a reality. It is no more like one of those viruses which is happening in some other part of the world and which we are far away from. After the Kerala thing, it happened with the Italians who were out here as tourists and who were admitted in Vedanta. And that was the first time uh, when any hospital, any corporate hospital, had admitted a few patients, and I was called upon to start testing. Maybe I'm one of the first ones, along with Dr. Lal, who started testing and was given permission by ICMR to do the test. Now, here, before I go further, I want to quote from one of the George Bernard Shaw books of 1936 called Doctor's Dilemma, in which he very clearly writes that very few doctors know how to say, I don't know. And here I'm going to emphasize the fact that as we go along these 90 minutes of journey, many a time I may be forced to say, I do not know, I don't know. But the fact remains that's only 6 months since the disease evolved, since the disease started. The government, surprisingly and pleasantly, was extremely proactive. They did not take this lightly. Immediately, committees were formed from Vijayaraghavan committee, different committees, under the Minister Dr. C.K. Mishra, etc., to see that the government set the pace correct. And ICMR was given charge. Usually it was the health ministry which used to be looking after, but this time ICMR was very actively involved into getting the ball rolling. So this was the background. And then started only with one lab in India, that was NIV Pune. And we all thought that one lab, that the National Institute of Virology, will be enough to look after the cases. But the cases started to grow. I remember going on an NDTV show when we had touched 100 cases, and we said, 100, my God, it cannot increase more than that. But look where we are now. Did we go wrong anywhere? I do not know. Could we have been better? I do not know. It's something like saying that if Virat Kohli had gone on the front foot and hit the ball, it would have gone for a six, but why did he go on the back foot? I do not know. Because those are decisions which were taken then, and the decisions were taken collectively by the government, by the private sector, with all the think tanks. And well, if we feel that we could have done better, I do not know.
May I interject, Dr. Dang? Because, see, this is a novel coronavirus. We are talking of February, March. No one globally knew much about it. We didn't know about its properties. We didn't know how it even transmits, how infectious it is, what kind of problems it can cause. And we know the devastation it did in the early months in the West, in the US, especially in New York, and in Italy and Spain. And so, I would like to bring in Dr. Anurag Agarwal and then bring you back in, Dr. Dang, because Anurag has been at the forefront of this fight. He is a researcher, he's also a pulmonologist, and he's head of a lab, which is a genomics lab. And we do know that India, in the beginning, was also very proactive in actually trying to learn more about the virus, trying to culture it, based on which. So, could you, Anurag, take us through what was going on the other side? And of course, we know that the government worked very closely in tandem with the private sector, and that's how we are where we are. Can you take us through the initial months?
Sure, Dr. Mahajan. So I think when it started, I mean, January, I guess the severity of what it is going to be was not fully understood by anybody. I would say anybody. By March, we had a much better sense of this was going to go south, this was going to go very rapidly downhill at that point. So by March, you can start seeing many government committees being formed. At least if you look at the verticals, one was molecular and digital surveillance. By that time, we had already learned from China. We knew it's an RNA virus. We knew the history of similar viruses in the past. They can mutate. Now, when they mutate, they can become better, they can become worse. You hope for better, but you prepare for worse. But you would only know that if you were either able to track the outcomes in a large number of infected people, or if you were able to track the virus. Now, given it is India, given that the virus by that time was known to produce at least a large amount of mildly symptomatic infections, truly asymptomatic spread came a bit later, to be honest. The idea was that we need to be starting to sequence the virus. Dr. Dang referred to the point it was decided in the early days that NIV would be the sole place where the virus would be cultured, sequenced, and things like that. And again, it's a Virat Kohli question. I mean, should we have gone on the front foot, back foot? Should we have spread the work around between multiple labs? I mean, for sequencing, for example, many of the CSI labs are actually better. But the point remains in March, we had decided that whatever be the previous decisions, let's get on with the business of getting the samples and sequencing them. And let's do that for the following reasons. The virus could be mutating. Number two, where has the virus come from? Because when a virus mutates, it also gives an opportunity to trace relationships. Where has this person caught the virus from? Is it spreading locally within India? Is it all imported from different countries? And I'll come to those results a bit later on. In case people are thinking of drugs, are areas within the proteins that these drugs target getting mutated? In fact, for relevance for vaccines also later on, which proteins you're targeting, are they getting mutated? And that became a major activity at IGIB and CSIR. In fact, we did, I think NIV did the first 10 or so, 10, 20. Then we did the next 500, then DBT did the next 1,000. Now we will release 2,000 more. So India technologically is well equipped. It was mostly a question of decision making, and you learn on the fly in a novel disease that nobody knows about, and you simply see where it goes. I remember meetings distinctly where the question was, how does it matter if only 2% variation come? I remember actually even pointing out that between a human and a monkey, there is only a few percent of difference. It does seem to matter. So,
Very true.
so I think we were technologically ready. We didn't fully grasp the magnitude of the problem in the beginning. Nobody did. But after New York, we all got on the ball immediately. And happy to answer any further questions on this, or would you like to go back to this?
What I would now like to do is probably bring in Dr. Velu, because or maybe before that, bring back Dr. Dang and talk about this main test which is there, which has been used, the RT-PCR test, which is the gold standard. Could you tell us something about it and why this was chosen to be the correct test? What is the background? Were there viral diseases in the past because of which we were rapidly able to do some pivoting and start testing for this? And then I'll come to Dr. Velu, who can tell us how they actually started the manufacture of these testing kits in the country. Because in the beginning, as we all know, there was so much competition for the limited number of testing kits that were available. So, Dr. Dang, can you tell us what is this test? How is it useful? What are its advantages? What are the limitations? And why is it technically so challenging?
Harsh, first thing is that as the audience which we are addressing to is not purely technical audience. So I'll try and be semi-technical only as a proceed along this small journey. And second thing, as I do not have a presentation in front of me, I may be missing out a few points. Please excuse me for that and feel free to ask me. I think it will be more interesting. I'll give a brief overview and then you can keep on asking me questions because that will keep the whole conversation more live, and whatever other points which I miss out, I'll be able to pin. So initially, of course, the gold standard, as we know, remains and is the real-time PCR. And of course, the times to come, we expect genomic studies to play an important role. And we are going to have more tests like CRISPR, which we call the Fluda of India, and the LAMP technology, which has been introduced by Abbott, also becoming major parts of diagnosis. But as we are right now, real-time PCR remains the gold standard. First time we have been doing real-time PCR for decades, and it was in 2009 that once H1N1 came, that was the time when lots of board labs, then the few standard ones came into establishing BSL2 facilities and starting doing the tests and became more familiar with the diagnosis, how to perform the diagnostic test. Real-time PCR basically requires collection of samples, which are nasopharyngeal and oropharyngeal samples. The nasopharyngeal sample uh, and oropharyngeal sample both combined together, and if sample taken properly, have got a sensitivity of about 70 to 80%. The sensitivity depends upon lots of factors, which I'll talk with you as we proceed along with it. The specificity is nearly 100%, but we have to be very careful that there's no cross-contamination and there's no carryover. Once the sample is collected, it is put in something called viral transport media, because the samples are collected from distant places and shifted to a central lab, which is a BSL2 lab, where the first part, of course, remains that we inactivate the virus. Then we do something called, which is the tedious part, which requires technique, that is the extraction. Why I'm saying tedious and technique is because not all labs are equipped with automatic extractors. And so I'll say that yes, it can be done automatically also, because initially when we started doing it, it was only with manual extraction. And as the work picked up, even for H1N1, then only we went in for automatic extraction. When the extraction is done, then the virus is taken out and is amplified. And the amplification takes place again in which is machine based. And we see graph. I can't hear you.
You're on mute.
When you say amplification, what do you mean by that? We understand that this is technically very demanding. Also, there's a lot of manpower that's needed. It's not that you put the sample in the machine and you come out with a result. There are various steps, and that's why it's not easy for any and every lab to do this test. What is amplification, and what is really RT-PCR? Can you tell us in simple words?
It's a multiplication of the genomes, which is there, extraction of RNA, and then multiplying it to a certain level to see if it is present out there and the number of copies which we get. So the number of copies which we get says that how much is the virus and the virus is there at all or not. If we are not able to identify the presence of the virus with the use of primers and probes, which are kind of materials will bind, there's a fluorescence emission. And we see the graph on the machine is out there, and we're able to say that if there's any multiplication which occurred or not. I'm not going to go more into it because of the time constraint and of the audience which is there. And here, again, when we're reading the graph is an extremely important thing. Every graph has to be seen properly. Like here, I'll slightly deviate from what I was saying, that lots of questions have been talked about CT values, etc., etc. Here I say that more than CT values, more than
we'll come to CT value and its controversies. And
I just want to say one thing, and I think Anurag will agree with me. More important in CT value is to see the sigmoid part of the graph and see the signal emission and the fluorescent emission. That becomes more important. But anyway, that is something else. So it has to be seen by a person who is technically qualified to read the graph. Then the readings are taken, and then we give the report. After the report is given, the lots of steps in between, which I'm not going to go into, but to say it is a step with a very high specificity, but average sensitivity. The sensitivity is dependent upon how the sample is taken. The sensitivity is dependent upon the kind of a gene which is which is targeted. Here we have two kinds of genes which we are targeting. One is a so-called screening gene as recommended by the WHO, which is the E gene, and WHO protocol says that target the E gene and then with the screening gene, and then go in for a confirmatory gene. In my experience, I find RD-RP as the best gene which for confirmation. But of course, like CDC says, N1, N2 gene also can be targeted. So they're very different genes, which is screening and a confirmatory. But I'm a strong supporter of the fact that at least two genes should be targeted, and only both the genes are positive. Then only we can give it a positive result. So this is the basic five-liner about RT-PCR. And then we have this is what it was, and this is what it is, and this is what remains the gold standard. And then, of course, we have in all these things, there's so many variables involved. The kind of swabs which are used, which have been proper, good quality swabs, the kind of viral transport media, the cold chain to be maintained, the extraction to be done properly, the amplification to be done properly by trained molecular biologists, the reading of the graphs taken properly. Here in my lab, every sample is read by me. By the way, I am a trained molecular biologist from Almy Institute of Medical Sciences, and I spent quite some time doing only molecular biology. That is why maybe at this time I find myself privileged that I have had a chance to serve my country, serve the people of my country. Because the training which I once had thought may not be of great use. But anyway, coming back, so this is the real-time PCR. And then
Yeah,
we have
we'll
some,
come back to it, Dr. Dang, because I want to involve Dr. Velu now. See, the
I was
scientists
finish about
at
the rapid antigen test first.
we'll talk about that later. We'll talk about that later. Because let's go in the chronology as the events unfolded. The rapid antigen test came later, as did the antibody testing, and we'll talk about them as we go along. Now, so in February, March, it was well known that the RT-PCR is the gold standard, and this is what we will need to do. Of course, there were groups around the world trying to look at other ways of testing, but RT-PCR it was. So coming to you now, Dr. Velu, you heard you run companies which manufacture medical equipment, which manufacture testing kits, as well as you run labs which do the testing themselves. Right now, I want you to put on your hat of someone who's to develop the tests. How did you go about doing that? In once the decision was taken that we are not able to get enough tests, even for the labs that were slowly increasing in number, and we need to have indigenous development as well as production of these tests. How did you go about it then? How
Yeah,
did the industry go about it?
thank you, Dr. Harsh. So it's basically, in January, when the virus struck in China, today Trivitron, as a company, we have factories in India, Finland, Turkey, and also in China. Ironically, we started a joint venture with our Finnish entity with China in November 2019. So when our joint venture started, the COVID hit. So obviously, then our joint venture started to do something on RT-PCR kits in China there. So that gave us some idea. But obviously, they were busy doing their own things. But we got some little ideas of what happened there in February. Dr. Anurag is here. So really, he remembers what we started. In March, first thing we approached was IGIB. So both Trivitron and IGIB started thinking, how do we, in fact, Dr. Anurag was kind enough to allow our entire team to be in IGIB for almost a month or two to really develop the first RT-PCR kit. So in fact, the origin of Trivitron's first RT-PCR kits come from IGIB. Then, of course, currently we are manufacturing in India, in Chennai, as well as in Vizag, and we have two kits. As Dr. Dang was saying, we have a 3-gene kit and we also have a 4-gene kit, which includes 1 internal control and 3-gene or 2-gene, which we use, and we have 2 kits being manufactured here. And actually speaking, this really resonates with what our Prime Minister says about Make in India. That is the first time we really realized without having products manufactured in India, we will not be. See, we all know health is wealth. And if we don't manufacture medical devices, even today is 85% import dependent. So this is the time, actually, even though the multinationals wanted to support us, they were also stopped by their own countries and they were all supplying to their countries. We had no choice, just no choice but to develop our own kit. And we started off in March, and by April, we launched our kit. Not only us today, we will be glad to know there are almost 90 companies producing RT-PCR in this country, and so many, and almost the whole variant of RT-PCR, VTMs and RNA extraction, automated RNA extraction. So this is the time actually the Indian medical device industry came for reckoning. So they really stood up to the country's need. And I right from very small companies in micro industry to the medium-sized and large-sized companies came forward and did it. And without this, today our RT-PCR test wouldn't have been where it is today. And more than the price, it's also the access. I don't think the availability of kits to come from other country was not a reality at all. So we had to really jump in and do it. And though we were producing other RT-PCR kits for different parameters and other things, but this was, as Dr. Anurag was telling also, none of us knew what it was in January, February. We had some little ideas coming from our Chinese JV. But otherwise, we had to develop on our own. Nobody could even send raw materials. Today, even primers, probes, and master makes, the three key components, these are under short supply across the world. So we had to also start finding ways to produce it in India. So that not only we could do the finished goods, we had to also get into doing the raw materials on our own. I think it would be the first, in my opinion. This COVID-19 is a huge crisis for the country, but also this crisis opened up opportunity to indigenize medical device industry in this country. When we could do something in a couple of months, why not a CT scanner or MRI or a cath lab or anything? So I think it gave confidence to the Indian medical device industry, and also confidence to government to support the medical device industry. DBT came in, CSIR institutions came in, all of them jumped in. ICMR did their job of controlling the quality, because the whole thing about doing indigenous general perception of many doctors today is Indian medical device industry does not have quality perception. So this is a general feeling, because as a consumer, they are entitled to their own views. But then ICMR kind of institution has to come in and say what is quality, what is not quality. So today, I think they acted like a referee and judge, though all of us had our own grudges initially, but we all realized that there had to be an umpire. Otherwise, there will be mess. So today, they have actually set the standard for all these kits. No longer people have to worry about when they are buying these kits, whether a large laboratory is buying or a small laboratory. They don't even ask anything. They say, is it ICMR approved or not? So this is the way I think we need to develop a manufacturing industry like our pharma industry went. I think it's time for medical device industry to take this as a clue and start. I don't think a 1.3 billion people market can be dependent on imports in medical devices.
Thank you very much for putting it in perspective, and also for saying that this is the time when the country needed it. The entrepreneurs like you and scientists like Dr. Agarwal, they came together. You saw an opportunity in adversity. And like we say in Hindi, marta kya na karta. We were not going to be able to import anything. And because the richer countries of the West were actually able to afford to buy anything at any price. And also, unfortunately, they got the disease about a month and a half before we did here. And so they probably needed it more. And that gave us time. But it was all because I feel the government and the private sector came together proactively, worked hand in hand, and that has led to this beginning. And what we've seen in the last 6-7 months is just phenomenal. This has really shown, and this was not jugaad. We talk a lot about jugaad. This was not jugaad. This was science. This was quality manufacturing. This was quality testing that was done. And on that score, I would like to bring in Dr. Om Manchanda, who runs the largest testing lab in the country. I do know that they have over 200 labs, probably 3,000 collection centers and 6,000 pickup points across the country. I heard this yesterday, so I remember the numbers. And Om, what really was transpiring? I know Dr. Velu, Dr. Dang, many other labs were working, but I do know that you were proactively involved with the ICMR in the beginning about testing, because suddenly in March, and especially as the lockdown was imposed, there was need felt that we would need to ramp up. Looking at New York, looking at Europe, we knew that we cannot escape this disease. We did delay it with the lockdown. We did find that time and that opportunity to get our things together. So, what was happening at that time, and how is it that from about 100 odd tests per day, which we were capable of in February, we have done 14 lakh tests about 6 days ago, and consistently across the country, we are doing more than 1.1 million tests. What happened? How did things come about that we are so well placed at this point of time?
Thank you, Dr. Mahajan, and good morning, everybody. I probably will not go into technical aspects. I think that's been spoken quite well. Uh, Last 6 months have been extremely challenging for every one of us. It's even more challenging for healthcare services organizations. And if you happen to be one of the leaders running such organization, life has been very, very tough. I think once we come out of this, probably a lot of literature can be written on management challenges. Uh, I actually recently read a book on forged, real leaders are forged in crisis. I think healthcare organizations will throw up many leaders in times to come because we are really been through crisis, still not yet over. Uh, I've had plenty of learnings in managing this situation, but I'll actually go into nitty gritties because some people in the audience, maybe in terms of what are the management challenges one faced. I think the first challenge which we faced was that when you start any new projects, you always get time. You know, there is a time to discuss resources, you get a time to plan it, and then execute it. I think in this particular thing, none of us actually got any time to plan. We just were put into fire. It's like your house is on fire. You're in a panic mode, absolutely no thinking. And today you get an approval, and tomorrow onwards you are expected to do testing. And call centers were flooded with these calls as if like everything is ready. And suddenly we went to a phase where there's a kit shortage, and I knew that kit shortage is going to be short-lived because some of these kit manufacturers had just got approval. So I think the first challenge was to put it all together, and I must say that everybody in the ecosystem, whether it's the kit manufacturers or labs, in probably 1 week's time, really put it up everything what was happening. The second challenge was none of us actually knew what is going to be the demand. As Dr. Dang was saying, we were doing 100 tests. We probably thought 100 is going to be the limit. It's not going to be more than that. Media channels calling up and saying that what is likely to happen. So how do you plan your supply side of business if you don't know what is the demand going to look like? I think the biggest starting immediate response for us was because it was RT-PCR test. All of us had some slack capacity of in the molecular department, and during that time, non-COVID business virtually had collapsed. So a lot of that capacity also was available. And I must say, during that period, a lot of these consulting firms, whether it's McKinsey or BCG, they really all came together and formed a group where we just collated all India capacity, which was available with virtually every lab. And I think it was like virtually 24/7. We all used to be on the phone with everybody, and entire industry came together. And we shared with that with ICMR and various state governments. And this is the capacity private players are carrying. And that was very helpful in planning the capacity as we moved forward. But this whole issue of what is going to be demand was always a big question mark. Now, there is another important variable in planning, which is the viability of the whole thing, right? So private enterprise actually has to be viable and sustainable for it to invest. There was a huge gray zone as to what is the pricing. Nobody knew what the cost is, how much kit is going to cost, how much PPE is going to cost. And all of this was not decided by the private players. It was actually decided by a nodal agency, and we started with some price. But we were all thrown into deep ocean. Every day there was so much of debate happening around prices, which everybody is aware. I think the another challenge nobody is talking about is that our businesses and most labs are attuned to serve a patient which is a walk-in patient. COVID-19 threw up a challenge which actually required home collection. And if you compare the capacity of what you can collect when the people walk into the labs and you calculate capacity when you go to somebody's homes, it actually shrinks by 80%. In fact, according to me, we have moved into a phase where testing capacity is one issue, but collection capacity is even bigger issue as the non-COVID business has come back. So
That's
there is a
very well put.
huge challenge on collection capacity, especially when you can't really bring these people into the lab. The other challenge we faced is that suddenly I think all private players thought that their headquarters have shifted somewhere else. We were all waiting for some instruction to come from somewhere and then tell our people what to do. As if like you get acquired and you have a new parent and you don't know how to run your company, right? Uh, the other challenge was essentially this, who is your primary customer? And suddenly and all of us sitting at the top of our hierarchy, the whole delegation shrunk. Everybody, the VIP customers wanting your attention, media wanting your attention, investors wanting your attention, your family wanting your attention. Virtually, you were flooded with everything, and you were at the focus of it. I think it was very natural, but I think that was a huge stress point for many healthcare players. I'll probably come back some of the lessons that I have learned from this as we go into this conversation. But I probably would actually say that this crisis, if you take a bit of a deep breath and take a pause, I think there are a lot of lessons on leadership in this crisis, and some of it I can talk about. How do you really lead a set of organization where you have large number of peoples? Especially company like us, we have close to 5,000 employees. When everyone had gone into a lockdown, and these people are expected to perform the duty, and where you are meeting an invisible enemy, and they are not only fearful of their own life, but their family set up everything, and to lead a group like this in that crisis was a huge challenge. I
I
think
think
I'm
that's a challenge which all providers have faced
absolutely.
over the last few months, especially in the lockdown when everyone was at home and they were expected to be out for much longer hours. Dr. Velu, would you like to add to what Dr. Manchanda has said, since you run Newberg Diagnostics as well? Were there similar challenges? Was there something different that you encountered? Because you
Yeah,
manufacture your own kits also?
yeah, of course, these two are two different businesses, so it has its own challenges. So when you come to diagnostics, that's the same. You know what Om said, that to keep the people motivated was the biggest challenge which we had initially in all these places. We also now have 3,000 people in different locations, and we didn't even start COVID testing in India when we started in also in South Africa. So in each of these places had its own challenges. The supply chain was a challenge. Price was changing week on week, month on month, because it was all not decided by us anymore. It was decided by governments, and between state governments there was competition. Each one was talking and setting different prices. And our ability, more than the doing one, he talked about collection challenge and also talked about the testing challenge. The other challenge we face is providing data. Whom do we provide data, and how fast you provide the data? So we have to give it to state governments, we have to give it to ICMR, we have to attend those meetings, and we have to bring in a lot of data entry operators only to provide those data provisioning. That also became a big challenge in the initial stages, and we all had to get into this RT-PCR apps. Everybody had to get used to get into applications. So I think the testing labs had but the real great thing about testing lab is, it just initially we thought we may not even have 100 labs. Today we have thousands. In the government has set up close to 2,000, and the private setup is coming to close to 1,000 labs. So I think the labs all stood up too, and I know large labs set up multiple PCR labs and even smaller labs. But one good thing in that, even during that time, I think NABL came in. We have to really appreciate NABL here, because they didn't allow anybody and everybody to do it and give the testing, because there had to be, we need to get some quality testing. So at least there was some basic need of NABL accreditation for every lab to start. So today we have RT-PCR, more than 500 private labs doing RT-PCR across the country. So I think government agencies and private agencies did their best. But the challenges continue because today, as the antigen test is coming, others are coming. So we need to know, because even patients are confused what to do. Earlier, the biggest problem we faced was we need to tell the patients without doctor's prescription, without following the ICMR norms, we can't accept. Imagine the VVIPs calling and says, we don't care, you get it tested. We have to really refuse all these VIPs and tell them saying, see, follow, there is something called ICMR. Many of them down south do not even know what is ICMR. So here we need to explain to even the real big VIPs of the city to tell them, see, these are the guidelines. We cannot do it. Second thing they say, you please do the test. Don't inform the government or ICMR. So these kind of requests were coming almost on an everyday basis. So we had to really face this day in and day out.
So you would say this pandemic has had one good effect. It has equalized everyone.
Absolutely.
It's brought everyone down to earth.
Rules. If it was our rules, nobody was ready to follow. When we said it's a central government rule, this is what they say. I think almost all had to follow. They had no choice but to follow.
So that's great. There has to be an overarching authority in a pandemic, even though health is a state subject, but someone had to direct. And I think, ICMR, CSIR, and all the 11 task forces that were formed by the government were very, very helpful in putting things together and in having them run in a very, uniform kind of manner. Now, I'd like to come back to Dr. Anurag. And, we've heard from Dr. Dang about RT-PCR, but I do know that at IGIB, right in the beginning, you were trying to develop a point of care test. Could you tell the viewers what is a point of care test? How is it different from a RT-PCR or an in-lab test? And what are we hear about this rapid antigen test, which is now being done in huge numbers. What are the advantages? What are the disadvantages? Will it help in the fight against COVID-19? Will it hamper the fight? Could you bring in your perspective to that? And then I'll go to Dr. Dang and take his views.
Thank you very much. Let me take one step back. The two keywords before you get to treat are trace and test, right? And to really trace, you must find as many infected people as possible. So simply testing, if you're not able to scale it such that you find almost everybody who's infected, is pretty meaningless if the plan is to trace. Now that changes how we will test. To do testing at a scale, Dr. Dang, when he was speaking, talked about the requirement of a BSL-2 lab, the VTM. Now, if you had a limited capacity, and the country has only a limited capacity of labs with BSL-2s and transport and all these things, and those of us who have done testing know it takes about half the time to unpack the samples coming to you. Only half actually goes into testing. So what do you want in an ideal test? That ideal test should not require a BSL-2. The virus should be killed at the point of collection. Number two, Dr. Om spoke very nicely about collection becoming a bottleneck. The test should use a biofluid that is self-collectible as far as possible. Of course, the test should be fast. If you get the results back much, much later, it doesn't help you very much. And of course, then come the economics thing, it should be cheap. And then of course, the performance characteristic, it should be sensitive, which means if you are infected, the test will pick you up. It should be specific, which means if you're not infected, the test will not give you false positives. Now, given all this, there are only three ways of going about it. This is an RNA virus. You capture the RNA of the virus. Every virus has a protein. You capture the protein of the virus, or you capture something the human being does in response to the virus. Now, starting with the last one, human beings responding, well, they respond very similarly to a wide variety of infections. So those approaches are never likely to be very specific. When you come to the protein, the problem is protein will be there in a small number of copies and you can't amplify them, which means increase the number. So sensitivity tends to be low. Specificity can be a bit variable depending on how you go about it, but sometimes it is very good. The nucleic acid is amplifiable, so it is sensitive. And the nucleic acid is very specific to the virus if you know the sequence. So it's very, very specific. So most sensitive and most specific are the nucleic acid tests. So the challenge really from a scientific perspective was how do you test for the presence of the nucleic acid while taking care of the other problems? And what are the other problems? Classical RT-PCR required viral transport media, live viruses, a huge amount of issues and took a long amount of time and required most importantly a quantitative PCR machine which costs about 20 lakhs plus, good ones. And most labs cannot afford 20 lakh machines that will have no capacity after the epidemic is done. So the way IGIB looked at it was number one, can we do something in which the virus is killed immediately and the RNA extracted without much processing because that takes a high level lab. I will not speak of the results for that, but around the world, people have already started moving towards saliva collection with heat-based extraction that kills the virus immediately. You don't need to go through much of the RNA extraction process. I'll come to the downsides of that a bit later. The second is, can you pick up the nucleic acid sequence of the virus without actually doing qRT-PCR? Now I'm distinguishing now the word PCR from qPCR. qPCR requires an expensive machine. PCR is a simple amplification of any viral sequence that can be done in a 20,000 rupee machine without any problem in 30 minutes. What you need is a sensor. So there's a group of enzymes called CRISPR. They find a very specific nucleotide sequence and they will bind it and they will cut it. Now, IGIB had built for sickle cell disease one of the world's most specific CRISPRs called FN-Cas9, which was on the cover page of a major journal called PNAS a couple of years ago. And what we realized is that by using this Cas9 as a way of binding to the sequence of interest and coupling it to a standard PCR amplification from a killed sample with a very small amount of RNA, we could make the entire process in such a way that without requiring BSL-2 labs in advanced machines, any small lab could do it. So this is a semi point of care, which is the care of a mohalla clinic, for example. Now, of course, in India, saliva and the other ways of collection are not allowed. So right now, the CRISPR test called Feluda, after a famous Satyajit Ray Bengali detective, which is actually a play on a similar test by MIT, called Sherlock. In their way, the CRISPR binds the nucleic acid first, and the amplification happens later. We do the amplification first and then bind our CRISPR later, but slight differences in the way we go about it. But both of us can do a readout on a paper strip. In our case, because we do the amplification first, the technique tends to be very specific. So we can directly do a visual band type readout on a paper strip, which is basically doesn't require any further equipment. And if we are allowed to couple it to, for example, saliva and RNA extraction free methods, we can do it without any PCR machine at all by using something called RPA that works at body temperature. We have a video of that out in the public domain. So these techniques are important because they can take it down to doctor's office. I personally do not believe any of these tests are suitable for taking to a patient's home. And I'll tell you the reason for that. The emotional trauma of being diagnosed COVID positive is something that you don't know, in the hands of an untrained person, how this would be. None of these are so simple that there will be no false negatives and positives. So I believe point of care in our definition goes only way as far down as the mohalla clinic. And, we talked about not jugaad. This is a fantastic example.
Or the PHC.
Yeah.
Mohalla
PHC
clinic
level.
or the PHC. Yeah.
If you basically bring it down to the level that requires a basic PCR machine, you need a basic path lab without a BSL-2, your local path labs, so as to say. If you take the RPA version, which is not yet approved in India, you can take it down to the PHC. But these are possibilities, but it's solid science. None of the science we did for this was built for COVID-19, existed in our labs through years of work. And that's where I completely agree with you when you say this was not jugaad by India. This was high quality science and cooperation. But one more thing I will say, the government like Brahma also has four faces. There is the Ministry of Health and Family Welfare, which basically is trying to regulate these things. There is the Ministry of IT that wants to collect all the data and help in the tracing. That's where you have those apps and everybody demanding you for data. There is, of course, the Ministry of Science and Technology, which says, let us also contribute, give us the samples, let all of you face this shortage of samples. The main reason Dr. Velu came to us was not because we had technology he needed from us, but we had access to samples being a government site. I mean, he will be too nice to say it, but I will say that. I mean, maybe there is some science from us that he needed, but mostly he needed us because we are one of the four faces of Brahma. And the last, of course, is, the industry. I mean, the protecting indigenous industry, regulations, Ministry of External Affairs, cooperation, very complicated things. I'm glad I only deal with the smallest face of Brahma, the science and technology.
But I think things have come together pretty well in this last 6 months. And may I now
Considering how
move?
hard it is normally, it
Yeah,
has been great.
yeah. May I move to Doc Dang? Doc Dang, we hear about these rapid antigen tests and that their sensitivity is limited. ICMR has given directives that if you find a negative rapid antigen test, one must do RT-PCR. Can you put the whole thing in context and where is it helping and harming us?
As before I answer your question, with due permission of the chair and the convener, I am very excited that I'm here with Anurag. And something has come to my mind. If you permit me, can I ask you, please?
Sure, sir.
Yeah,
Please
please.
permission to ask from Anurag. Anurag, I've been reading about CRISPR since quite some time, and I've been very much enchanted with this paper-based technology. As rightly have named it Faruda and the Sherlock, which is there abroad. How does it, but again here, we require RNA extraction.
So we don't actually, I mean, if you use a saliva with a heat treatment and a lysis buffer, you can work straight from it without RNA. The sensitivity drops to approximately 10%, most of it for high CT samples on a normal things. But you can easily couple it, as University of Chicago has shown. You don't actually need RNA extraction, but yes, sensitivity would drop to
Number
by
two,
about 10 to 20%.
number two, how does it compare with the LAMP technology as introduced by Audi? Because I have, while talking to you, this very small footprint machine based on LAMP is lying in front of me. I wish I could move it to show
Yeah,
it
about
to you.
right.
It is not even a foot or half of it big, and here you do not require any amplification. It's just the straight swab is to be given. As compared, initially, I should have talked about cartridge-based testing, that is the secret.
I think that'll complicate things, Naveen,
I did not want to worry, but I want.
because we have a mixed audience, and I think we could take this one on one. Let's talk about the rapid antigen
Why
tests.
I asked about
And
this
yeah,
application was because the LAMP technology, because I feel that
I
this
can answer in
and
one
LAMP
line.
are the future.
I can answer in one line. LAMP and RPA are comparable technologies for amplification. What determines your sensitivity and specificity is how you read out. The easy ones, which are visual, don't have very high sensitivity and specificity as of yet. The ones that require fluorescence require you to have a fluorescence machine. The advantage of some of the CRISPR methods is you can make it machine free, just one pipette, 3 tubes, and a 37-degree block, and you can use your own elbow if you choose to. I'll stop there, but we'll take it offline for.
yeah. Thank
Thank
you.
you.
So,
Thank you much.
welcome, Dr. Nangia. Dr. Vivek Nangia has joined us. Thank you for taking this half an hour out of your schedule and seeing patients. I know you have hundreds of COVID positive patients that you care for. Thank you very much. And Dr. Nangia, as I had said earlier, is the head of pulmonology and critical care at the Max Hospital in Saket in Delhi, and has a huge experience of treating COVID patients. And his clinical acumen and his experience of treating them will actually help in putting into context what we are talking about, the testing. So, Dr. Dang, difference between rapid antigen test, the antigen-based test, and RT-PCR, and what is the difference?
Comparing apples to oranges, and that too, if you permit me to say, to rotten apples. In the way that I see that I am one of those who is strictly propagating the fact that rapid antigen test is far less sensitive, and it is being used, unfortunately, much more, which is giving misleading results. I'm being very candid in my statement. Please pardon me for it, those who are listening. It is only meant to be tested in hospital where it's being tested. And it is very clearly said that if positive, it is positive. If negative, then if patient is having SARI or I-like kind of symptoms, then should be tested by RT-PCR. But my problem here is that once the patient gets tested uh, negative by a rapid antigen test, they're no more going in for getting the RT-PCR test done. Let's admit to the fact that when a patient sees negative, he, in spite of the fact the physician may tell him, but tell him to go ahead and get it done, they're not going in for RT-PCR. This is where the main roadblock is occurring. This is what is causing the disease to spread. And I humbly request all those who are listening that not much importance should be given to a rapid antigen test. Yes, it has scaled the numbers. Yes, it has increased accessibility. All gurdwaras, community centers, RS mandals, etc. have been dropped in for doing the test. But are we actually following the correct course? Are we not misleading? It is better not to say that I can't do it than to do something which will give a false sense of complacency to the patient. When the patient sees a negative report, they say that's fine. We won't go in. Despite the fact that ICMR guidelines clearly state that once negative, get yourself tested for by RT-PCR if follow the criteria, which I will not go into, contact with a high risk patient, I-like kind of symptom, etc., 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 etc. But patients don't. And they go out happily, merrily, and spreading the disease. In the RS Mandir, Gurdwara, community hall, there's nobody there to guide them. There are only just those paper clippings out there that do this, but nobody is doing that. I've had the innumerable number of patients whom I feel should not have got the rapid antigen test. So
okay, now I see that Dr. Anurag is quite keen to come in. And the fact is that this, as far as I know, is a test which, when it tests positive, there is advantage in that, because as Dr. Anurag started, that test and trace. So if in a containment zone or in a high area where there are high numbers, if this test is used, you can actually pick up the patients who are positive, isolate them, treat them as the case may be, and also trace their contacts. Of course, once the numbers increase beyond a limit, then that may not be possible. But let's hear what Dr. Agarwal has to say. And then we have Dr. Nangia, who can start with this controversy that is there about rapid antigen tests. And Dr. Nangia, then I would also like you to talk about where you think in the clinical field the antibody test fit in. So,
I'll
Anurag.
try to be brief, but as a sole representative of the government over here, I feel it upon myself to explain the logic. There is no perfect test, like I said. The point is the use case scenario. People in whom you have a good suspicion of COVID, you should never use a rapid antigen test first. But if you want to go screening in a predominantly asymptomatic people, in a good pretest probability, say 5% or so, a negative test gives you a very substantial negative predictive value, and a positive test also gives you a good positive predictive value. So it's a nuance test, and the topic of today's discussion is about the nuances of diagnosis. So if you use the rapid antigen test correctly exclusively in that population, where you are basically taking asymptomatics, you're trying to expand your testing beyond what your RT-PCR system was capable of. Most of those problems created by our own sampling strategy of VTM, etc., and swabs, collection becoming a bottleneck. This is the only way out of the situation, but it must be explained properly to the workers implementing this in the field, exactly as Dr. Dang said. This is not a test to be used for a symptomatic patient. And if you choose to use it for a symptomatic patient, you must follow up with an RT-PCR. But the basic idea is expand the reach outwards of people who otherwise would not get tested at all. That is the use case scenario.
I may, just give a small rejoinder to that. If we look at the numbers in Delhi, about 20% of all tests done are RT-PCR and 80% are rapid antigen tests. Probably it should be reversed. And definitely there is about 35% of RT-PCR capacity in Delhi, which is unutilized. So that's where the problem is. And also, the symptomatic people who turn up negative on the rapid antigen tests, unfortunately, are not being tested with RT-PCR. So the consequence of all of this, the thought behind the test is fine, but the consequence of the practical implementation is that many symptomatic people and many positive people are going away thinking that they are negative and not getting RT-PCR done, slipping through the sieve
I
and
fully agree.
consequently spreading disease in the community. That's where probably things are not going the
Yes.
way the planners had planned.
Intended.
And so there has to be some kind of balance which has to be drawn. Of course, on the plus side, it is able to pick up those who are positive, and you can isolate them. But on and the other plus side is, it to the world, it shows that India is doing huge numbers, 1.1, 1.2 million tests every day. But if we are missing out the positives, then we are doing a disservice at some point of time. And that's why it's a nuanced test,
Yes.
but probably the nuance is lost somewhere in the transmission of the test from the planners to the implementers on the ground. Dr. Nangia, thank you very much for joining. What do you have to add? You are seeing this on a daily basis. What is your feeling about this little controversy that is there? Kindly unmute yourself. Dr. Nangia, please unmute yourself. You're muted.
Sorry about that. So, at the outset, I'd like to thank you, Dr. Mahajan, for having me on this prestigious platform. It's indeed a great privilege for me to be here today. Now, as far as this debate is concerned, my point of view is that my perspective of this entire debate is that it's a wide spectrum disease, and every test has its position. You just need to position it properly and use the test properly. So the debate of antigen versus, so there's also something called CBNAT in between that I guess we've missed out in the debate, because many centers are not using CBNAT as a test, but that also is a probability of using it, which has an
Dr.
in-between kind of a
Dr.
sensitivity
Dang
and
alluded
specificity.
to that, cartridge-based test. It's an expensive test, and in a
Antigen and the
scenario,
RT-PCR.
yeah, it's as good as the RT-PCR, and it's a test for the viewers where you get a report back in 20 to 30 minutes. It's cartridge-based, expensive, and probably because there is capping on prices of these tests, consequently, it's not much used. Also, you can't do large numbers. You can only do limited numbers. Please go ahead, Dr. Nangi.
Yeah. So next thing is that antigen is more of a screening test. An antigen-based test is for screening purposes. If it turns out positive, well and good, you can start treating the patient. But if it turns out negative, and there is a high suspicion of the disease being there, then you would certainly want to subject this patient to an RT-PCR. There are also situations where you test RT-PCR once, you test it second time.
We seem to have lost Dr. Nangia. Probably.
I think he's gone on mute.
Vivek, you're muted again.
I'm back, Jay. No, I'm back. So I was saying that, if there is somebody with an antigen test positive, very good, you can treat them as COVID positive. If antigen test is negative, then you would want to subject the patient with a clinical suspicion to an RT-PCR test. If RT-PCR is negative once, second time, you get a CT scan done, and that's still sensitive to an RT-PCR. And if there's a classical picture where you get peripheral patchy opacities, GGOs, bilateral symmetrical, even asymmetrical ones, basal, and the classical peripheral distribution that gives you a clear-cut indication that yes, this is COVID. So, in the clinical practice, we keep debating between these microbiological tests, but so many times you have to treat the patient based only on the radiological picture, where there is strong suspicion that there will be nothing else but COVID. So what do? You have to treat them. So as I said, every test has its own position. You just need to use them appropriately. Antigen test we use for screening. RT-PCR we use for diagnosis. And if that is negative, then we go on to the CT scan and then confirm whether this patient is having COVID or not. So besides all this, it's the basic history that is very, very important. A history of exposure, history of contact, history of travel earlier, but now no longer travel matters really because now it is happening all over the place. So a proper classical history of fever, body aches. We have patients who have classical history of fever, body aches, and which has been going on for the last 2 weeks, 3 weeks. Negative. Attribute them, I don't know. These scans also turning out to be normal. But there is some of COVID which is resulting in a low-grade fever. 99 to 100 fever.
Dr. Nangia, we are not able to hear you well. Your signal's weak. Just turn off your, video, and we'll be able to hear you much better.
Okay.
And thank you for bringing in radiology into the mix, because that has a very important role to play, especially when repeat RT-PCR tests are negative.
Opportunities where we diagnose based on radiology, rather than just RT-PCR or a microbiological diagnosis. And we've treated such patients also on similar lines. The problem is that we still don't know what is the most appropriate sample to be taken. Is it the nasopharyngeal, oropharyngeal, nasal, pharyngeal, saliva, or a deep respiratory secretion? What is more appropriate? Collection of the specimen.
I think we've lost Vivek. If I could just take off from there, there are times when clinically you're very sure that you're dealing with COVID-19. And we've had patients where even repeat tests 4 times were negative, RT-PCR negative, because we do know it depends on the technique of collection, it depends on the viral load. We do know that the nasopharyngeal swab has a higher sensitivity as compared to oropharyngeal. But with repeat negatives, what has been now, this is quite accepted, that if a high resolution CT scan is done in these patients, then the sensitivity of the CT scan is 90 to 95%. And based on the CT scan, seeing the typical lesions, one is able to then determine that one is dealing with COVID and treat accordingly. So there is this role of radiology, especially CT scan. The X-ray also may have a role, but it's a limited role because the sensitivity of the X-ray is much lower than of a CT scan. So when a doctor tells you that even though your RT-PCR is negative, but I think that we are dealing with COVID, kindly get a high resolution CT scan, then you should go ahead and do it. Of course, there are logistics issues, safety issues, which the department faces in getting a CT scan done. And that's why either you go to a designated hospital, which treats only COVID-19, or radiology departments within hospitals have designated time when they build a green corridor so that the non-COVID patients and their own employees working in the hospital are not affected and do not get exposed to a COVID positive patient. Also, there is a very strict regime which has to be followed for sanitizing the room as well as the CT scanner or the X-ray after a COVID positive X-ray or CT has been done. So radiology, one role is in this specific clinical situation where the RT-PCR is negative, you use a CT, and of course, repeat X-rays over time have a great role to play in the ICU, in the ward, to see how the pneumonia of COVID is proceeding. Is the patient getting better? Is he getting worse? Are the lesions increasing? And on a CT scan, one can even predict, based on various factors which we won't go into, whether a patient will actually deteriorate to a level that he may need ventilatory support. And these are prognostic factors which you can determine. So, apart from molecular diagnostics, there is also the role of radiology. And again, it has to be really nuanced. I would now, is Dr. Nangia able to hear me?
I can very well, sir.
Yes, yes, great. Kindly go ahead and tell us how you're using X-ray and CT in your hospital while treating patients.
So when we are treating patients with COVID, then initially what our usual protocol is that on day, so again, it will depend on in what duration of history does the patient have. You know, first 2-3 days, one would not go in for a CT scan because you would expect the CT to be normal. But probably 7th or 8th day is the time that I usually get a CT scan done for most of my patients, because that is the time where we feel that the viral load is now less and it's more of an inflammatory process that the patient is undergoing. So this is the time when you may want to consider adding steroids or oral anticoagulants. So that is the time where we use a CT scan. 7th, 8th day is the usual time frame when I get a CT scan done for my patients. But then again, CT scan has also defeated us quite a few times where, you know, 2 days prior, CT was absolutely normal, or maybe had a very small score, say 2, 3. Okay, hold on. So before I go on to that, I'd like to say that, you know, for every CT scan that is done for the patients, we do what is called a CT severity scoring.
Yes.
CORADS first and then a CT severity scoring, depending on the lung involvement. And the score is from 25. 25 is the maximum score that a patient can get. Maximum means the worst score, actually. No, it's not a good thing to have. The worst score that a patient can actually have is 25. And but then, you know, there are times when 2 days prior the CT scan showed a score of 2 and 3, and you're confident that yes, this patient is doing well, and then suddenly they deteriorate. These are the patients where the score suddenly jumps from 2 to 3, from 11, 12, 15, 20. So there is no range. You know, these are the patients who are then going into a cytokine storm syndrome. So what is the role of CT scan? One is to give us a baseline kind of an information that how bad the lung disease is. You may want to add steroids. It helps us rule out a secondary infection if there is one. You may want to treat it. We've had patients who've had a fungal infection which could have only been diagnosed on a CT scan. So role of CT scan in diagnosis secondary infection is very, very important. Third thing where we place our CT scans is where the D-dimer levels are high, or when there is a sudden deterioration in the patient's clinical condition requiring very high flows of oxygen, and the X-ray picture is not so bad. That is when we consider the possibility of a pulmonary embolism, and we do a CT pulmonary angio in these situations. Also, what we do in these patients is usually if the D-dimer levels are very high, then we also get a lower limb venography done or an abdominal venography done, basically to see if there are any clots there. And yes, we have in quite a few patients detected the presence of a DVT, a deep vein thrombosis, and we've also detected pulmonary embolism in quite a few cases. So this is where the role of CT scan comes in and is invaluable in the management of patients with COVID.
Thank you very much, Dr. Nangia. Just one other quick question before I let you go. Are you, when you're discharging the patient, what is it that you do? Do you do a repeat RT-PCR? And quickly, since you have to go, I'd like to request you to tell us about the antibody test and where you're using it and where you think it should be used. And after that, I'll have Dr. Anurag Agarwal come in and talk about artificial intelligence algorithms that are being built for COVID-19 X-ray and CT. Dr. Nangia, please.
So there are two questions that you asked me, Dr. Mahajan. So let me start with the first one. Are we doing RT-PCR test before discharging the patient? Well, you know, patients themselves don't feel satisfied going back home without an RT-PCR testing. Although if you go by the Government of India guidelines, they say there is just no need. You just watch the patient from the 10th day of onset of illness and 3 days without fever, you're safe in discharging the patient. But clinically and On ground reality, it really doesn't happen sometimes, because suddenly you see we've had patients where RT-PCR was negative. We had planned a discharge for these patients the next day, and suddenly they deteriorated and went into a cytokine storm syndrome. So rather than going blindly by the guidelines, what we actually do is we monitor the trend in their biomarkers, the inflammatory biomarkers, CRP, D-dimer, ferritin levels, IL-6 levels, along with, of course, the CBC, LFT, RFT. And if there is a settling trend, so, there are patients who come with the normal levels, then there is an elevation in their levels, and then they start to plateau and then start following. So if somebody is following that typical curve, we are confident in sending the patient home without an RT-PCR. If these biomarkers are still not settled and it's been 14 days of illness, then you would consider an RT-PCR before sending these patients home. And then we would usually do 2 RT-PCRs before sending them home. Actually, patients themselves feel that rather than going back home, isolating themselves, exposing the other family members to the COVID, they'd rather have the RT-PCR tested here before they leave. So they sometimes demand it themselves. That was the first part. Second part was about serial CT scans. Serial CT scan we would usually do in the later phase, 3rd week or 4th week, when you're actually tapering their steroids off, and where you would want to decide whether this patient is going into a fibrotic lung or not. So if the patient is showing any signs of pre-fibrotic lesions or extensive involvement in the lungs, then you may want to consider treating the patient with a prolonged course of steroids, or maybe start an antifibrotic or something of that sort. So those are the two situations. Those are the 2 ways that you monitor these patients.
Also about antibody testing, because
Antibody,
you do
yeah, that's
a lot of plasma therapy as well.
Yes. So antibody test is highly misused test, I feel. I know of people who've stocked these antibody kits at home, and they test their antibody test every day and then feel very happy, oh, it's negative. They don't realize that negative is not the good thing to have. A positive test is better. So antibody test is basically used in a clinical practice when patients have come in with breathlessness, have repeated RT-PCRs negative, as you said, 3 PCRs, 4 PCRs negative. CT scan is showing the classic COVID picture. That is when we do a COVID antibody test. IgG is what we test to see that whether this was a COVID illness or not. Is it that we're dealing with a post-COVID sequelae now? And that has turned out to be positive quite often. We have quite a few such patients where everything was negative, CT was classical, but COVID antibodies have turned out to be positive. And these patients did not even have fever in the past. So there is some kind of a low-grade afebrile illness that they had, which resulted in this COVID lung, and now antibodies being positive. So that is where the role of antibody is. And second role of antibody is in plasma. When you want to have a donor, when you want to donate your plasma for convalescent therapy for the benefit of the others. So that is when we use the antibody test and over.
Also, as we know, it's a great test for serosurveillance, for
Absolutely.
knowing what degree of population is already infected. And I think today we got a survey done by ICMR, which is telling us the situation as of end August in India, and it says about 6.6% of our population has already been infected and recovered, and many don't even know. We know that there are a huge number of asymptomatic patients, and so that's the other area where it's very, very useful in determining the number of people in a area who are infected.
So, Dr. Mahajan,
have,
one thing we need to note here is
yes,
that even the IgG turned out to be positive only after 2 weeks. So if you're saying
yes,
6.6% have turned out positive, and if they were tested probably prior to that 2-week of period, then maybe we would have had a much higher number. What I'm saying is that there still would be a large number who have tested negative, and yet they might have been exposed to COVID illness.
Yeah, thank you very much. We have just 2 minutes left. And Dr. Anurag, a word from you about artificial intelligence algorithms. I do know that IGIB is also involved in that, along with the other groups. Where do you think we are?
I think the AI can be divided into 2 parts. One is for radiology, where it is very well established. As you yourself said, and Dr. Nangia said that as well, when the clinical suspicion is high, but the molecular diagnostics are coming out unexpected. There are multiple possible reasons, because when you use that as a denominator, the sensitivity of RT-PCR is 80% only. And you don't have radiologists, very common problem in country like India, or you don't have experienced radiologists. Tremendous role for AI, better for CT than for X-ray. But you take what you have, you live with it. Every test has its own particular scenario. If you are suspecting a COVID pneumonia, even an X-ray might help you, and AI will be useful. And of course, we use AI even behind the scenes in genomics. Every time we assemble
Yes.
and interpret a sequence, it's all AI running behind the scenes. We don't even think about it. So
Thank you
yes,
very much.
tremendous
And final, we have a question which is to everyone actually, but first to Dr. Om and Velu and Dr. Velu, and then to Dr. Dang. Uh, do the panelists observe any differences in performance between various RT-PCR kits that are available in the market today? And this is from Dr. Vidur Mahajan from Delhi. Om.
I think Dr. Dang probably should answer this. I think our protocol is we obviously validate these kits before we adopt it. I know lots of kits are approved by ICMR, but we have an internal protocol to validate these kits before we adopt them.
Uh,
Dr. Velu and then Dr. Dang will have the final word.
Yeah, as Om said, basically the kits are of varieties. As we say, somebody is using different genes, 2 genes plus an internal gene. Somebody is using 3 gene plus an internal gene. And many of these kits on a typical validation sometimes give 100% and 100% sensitivity and specificity in ICMR report, but in reality could be 99%. So that could be 1%. And again, the lab processes and the equipments we use, the settings in those equipments, all these are variables. So it is important for every lab to validate the kits and the protocols themselves rather than blindly following something is approved by ICMR or USFDA or any of that. So it's important, like we do that in the laboratories almost all the time. This is what NABL also says. Independent of the fact something has been approved by USFDA or ICMR, you do internal validation. That's what just Som said. I'm sure every lab should follow that and build their own protocols and choose their kits, not blindly follow what is being told, because there's a lot of variables before getting a good quality RT-PCR results out.
Dr. Dang, just to put it in perspective, many times it has happened that a test came positive in one lab and then tested, 1 or 2 or 3 days later. In fact, at times even later than that, it came negative. And if that lab happened to be a government lab, the private guys have been hauled up over time. So is it to do with the kits? Is it to do with the disease itself? Is it to do with the way the test is run? And is someone at fault?
Harsh, thank you for asking this very, very pertinent question, which has troubled, I think, most of the private sector labs sometime or the other in the last 6 months. Firstly, it should be understood that all the private sector labs and the government sector labs are putting in the best, using the laid down protocols, using the kits as recommended by ICMR itself. But as my friends Om and Will, etc., have rightly said, we all have validated the kits in our own labs under the existing circumstances. Uh, Regarding question of a patient testing positive one day and testing negative the second day, it all depends upon the disease itself. It has nothing to do with having the test having gone wrong. The sensitivity, yes, definitely yes. In which I can say it can be depending upon how the sample was taken, how the sample was transported, etc., etc. There are many different variables which are there for the sensitivity. As we know that for nasopharyngeal swab is not taken properly, the sensitivity as such, which is claimed to be about 68%, is becomes lower. If it's an oropharyngeal swab, again, the sensitivity becomes lower. If both are combined together, taken properly, the sensitivity is about 80%. Remember one thing, the maximum, and Rag maybe can guide you better, but the maximum sensitivity which you can get is 80%. The specificity is, of course, 100%. It all depends upon the disease process itself. In
I
my
have
own
one
lab,
more question.
about CT value,
We let CT value go. I have one more question, and this is to do with the fact that even in patients who are completely healed, the RT-PCR test may come positive day 20, day 50 even. In fact, I think what I've read, the maximum is probably 65 days it came positive. When do you stop doing it? And then could you, the two of you, I'm taking this liberty from the organizers, 5 more minutes, and talk about CT value and its controversy.
Okay, Anurag, I'll talk about CT values. You talk about how long the test can become.
So in people with normal immune function versus compromised, the numbers are of course different. The person who entered the 3rd month positive had some defects in their immunity. We are now seeing lots of people having antibodies to interferons and difficulties in mounting interferon response, even within normal people. So I suspect that the virus will, even in normal people, can easily cross a month or so. We have seen multiple such cases. But to be very honest, by the end of this, very few people have, well, we'll come back to the CT immediately the minute I say this. Very few of them actually tend to have CT values in the range that we now believe to be transmissibly infectious. So there is some degree of caution in that, which gets very complicated. And I'm going to bounce this right back to Dr. Dang, because whether CT is reliable in determining infectiousness is itself a controversial topic. But this is a tough one, so I'm going to give it to him.
We can also, maybe before Dr. Dang has the final word, maybe Dr. Nangia, if he's still here, how do you, discharge a patient who's repeatedly coming positive, even though you're sure he's completely healed and will not transmit disease to anyone? Is Dr. Nangia there? I think he's been called away. Dr. Dang, all yours now for winding up.
Just 1 minute. Cycle threshold values has become a very controversial thing in my practice in the last 1 month or so. Remember one thing, what we're doing in RT-PCR, it is not a quantitative test. It is a qualitative test. Please remember, the cycle threshold is defined as the number of cycles required for the fluorescent signal to cross the threshold that exceeds the background level. I'm right, Anurag?
Yes,
so it is said that CT levels are inversely proportional to the amount of target nucleic acid in the sample. That is, the lower the CT level, the greater the amount of target nucleic acid in the sample. Am I right, Anurag? But this is dependent on so many variable factors. It is dependent upon the kind, I was going to answer this question before, again, the question was passed on because of Nangia was giving. It will vary from the kind of extraction, RNA extraction that is done. Is done manually, is done with a Thermo Fisher extractor, is done with a Roche extractor, is done with a Kaizen extractor, etc., etc., etc. It will vary with the kind of equipment that is used. It will vary with the kind of sample collected. It will vary with the amplification. There are too many variables involved in it. When we say we cannot be comparing two different labs giving the same CT values at all. So CT value in my own lab, if today is 28, and after 3 days, the patient gets the test done again for my own lab, it will instead of becoming higher, it may become lower again by say 26, 27. This opened the Pandora's box to the patient. The patient gets after us that 4 days back, you gave a CT value of 29, 4 days have elapsed, the patient is feeling much better, the CT value has come down to 27. Dear sir, please remember one thing. We are dealing, give me half a second more, we are dealing with a illiterate, semi-educated population as far as this aspect is concerned. And to have videos floating around saying that CT value is dependent, is the sole criteria for seeing if we're infective or not, if we're capable of transmitting the disease or not, is totally wrong. I humbly request to follow the 5th August ICMR guideline, which clearly says that CT value should not be used for either monitoring the disease or monitoring the transmissibility of the disease.
So on that, I would like Anurag actually to come in, and I'll say that this is going to be the final finale. do you think, because what we are told by the physicians is that ICMR has given a long directive about not using CT value for so many reasons, but it hasn't banned the use of CT value. They say उन्होंने बंद तो नहीं किया है. You have to give it, and that may lead to improper treatment. So, do you think, since you are the only representative from that side, it would be a advisory which says CT value is banned, it should not be given? Would that be useful?
Let me give a nuanced answer to this question. ICMR is correct when it says that CT values are not to be used by the general population to make determination. It's a very nuanced number, exactly wonderfully explained by Dr. Dank. In the hands of the right people, it could be with the right constant set of characteristics. You can say that when the CT value is very low, the viral load is very high. You cannot say very much when the CT value is high because it could be your extraction, it could be God knows so many other things. Some information is there, better used by researchers, not to be used by the public. I think I would end there. So
it should be banned. You are saying it should be banned except for research use.
Yeah, CT values for public consumption for self-decision making is a bad idea.
So
thank you very much.
So Dr. Agarwal, I have a suggestion. I'm using this opportunity. I think this can be discussed internally. Probably an advisory can come out that what we should be writing on the report or not. It will help because it's creating a lot of confusion in the system.
I know we will bounce this one to ICMR because, like you know, there are so many so many forces.
Okay.
Yeah.
On this one.
Thank you very much. I must say we've had a great interaction here. The luminaries on the program were such that we could go on and on discussing. We've really barely scratched the surface, but then we are already 11 minutes over our designated time. And much as I would like to continue talking to you and learning more, we have to call it a day. Thank you so very much for joining. Thank you, FICCI Heel, for giving us this opportunity to discuss about the nuances in diagnostics for COVID-19. And thank you, Arati. And it's now over to you. And sorry for overshooting.
No, I think it was an absolutely brilliant session. The depth of information and all the questions that have been answered, the struggle that all of you have gone through as a reflection of the entire industry. It has been a brilliant session. In fact, I wish we had a little more time to carry forward the discussions. And I must compliment Dr. Harsh Mahajan for getting out provocative questioning and getting out the depth from all the insights from all the speakers. Each one of the speakers has performed it, done the talk and given their experience in a fantastic manner, which I'm sure is going to be cherished by all the people who have listened in. And also these, talks are going to be, sessions are going to be recorded and put on YouTube. So for the larger public viewing. So thank you, Dr. Manchanda, Dr. Agarwal, Dr. Naveen Dang, Dr. Velu, and Dr. Vivek Nangia. I think he's had to rush to see his patients. He's extremely busy with the COVID workload these days. So with that, we would like to conclude. Thank you, Dr. Mahajan, for chairing a brilliant session once again. Thank you. Have a good day and stay safe, everybody.
Thank you.
Bye-bye.
Thank you.
Bye-bye.
Bye. Bye. Thank you all very much.
We are live now.
Good afternoon, everyone, and very warm welcome to you on the last day of September. So, in continuation with the scientific sessions of this lovely conference that FICCI has put together, myself, Dr. Aarti Verma, wish you all a very warm welcome to the speakers, the panelists, the chair, and the delegates. This session is going to be, the theme is current therapies and their effectiveness in managing this pandemic of COVID-19. We have a panel of very, very distinguished speakers and professionals who bring with them a phenomenal amount of learnings, knowledge, and reputation. The session will be chaired by Dr. G.C. Khilnani. He is the chairman of PSRI Institute of Pulmonary Critical Care and Sleep Medicine, formerly professor and head Department of Pulmonary Critical Care and Sleep Medicine at All India Institute of Medical Sciences. I would like to warmly welcome Dr. Khilnani to chair the session. A few words about him. Dr. Khilnani has over 40 years of work experience in his field, in AIMS and now at PSRI. He is also the past president of the National College of Chest Physicians, an active member of Council of International Governors and Regents, American College of Chest Physicians, and Executive Council, Indian Chest Society. He is also the chairman of the Credentialing Committee, Indian Society of Critical Care Medicine. So looking forward to a wonderful session. I would like to hand over now to Dr. Khilnani to chair and moderate the session. So,
thank you. Good afternoon, everybody. Thank you, Dr. Aarti, for a kind introduction, and thank you to FICCI and all the office bearers, especially Dr. Harsh Mahajan, the organizing chairman of the scientific program. And I'm actually delighted to be here, and the subject given to me is also very close to our heart and everybody's heart, if somebody is a doctor or if not a doctor. And I have an amazing set of faculty who would be detailing on the subject, and my job will only to facilitate it. The drill would be that first there will be 3 presentations on therapeutic aspects, and then we'll indulge into the case-based discussion. If I was to detail the biodata of my panelists, we're spending too much time, I'll just give a brief introduction. So first I'll introduce Dr. T.S. Clare. I can safely call him King of Cardiology. He's my senior at PSRI Institute of Cardiac Sciences. He's a Padma Bhushan, and his field of specialization is electrophysiology. So anything in cardiology, we rush to him. And then Dr. D.J. Christopher, he is the head of Department of Pulmonary Medicine at the iconic CMC Vellore. He also happens to be president of Indian Chest Society. Dr. Chabda, amazing pulmonologist, and physiology is his specialization. Presently, is at is working at the hospital. Sorry, I'm not getting his name, that name. And then Dr. Dr. Rajadhar, he's also a member of Indian Chess Society, trained in India, also in UK. He is heading the department at Fortis, Kolkata. And my colleague, friend, and in some way my guide also, Dr. Anjan Trikha. He is by education is anesthesiologist, but amazing critical care physician he is. He is also has a credit of working in New Zealand. And to tell you very honestly, anything in anesthesia and critical care, anybody names will just rush to his office and take help. Anything, So I have not gone into any kind of biodata in the interest of time. And so let's get started. get started, and first I'll invite Dr. Christopher to tell us actually how he would treat as far as the therapeutic aspects of mild COVID disease is concerned. I don't have to introduce that we have 3 crore cases and all those things. So, Dr. Christopher, all is yours for next 12 minutes.
Thank you, Dr. Killani.
Sorry,
Thank
sorry.
you.
Before you, sorry, there's an omission. Since it was not on screen, I must introduce Dr. Ankur Purik. He studied in Delhi, but now he's working as a pulmonary and critical care physician at the Pittsburgh Medical Center, and he has 23 years of experience of working. And he, since it's almost past midnight there, so we'll be having his recorded presentation on critical care aspects of COVID. Sorry about that. Yes, DJ, all is yours.
Thank you, Dr. Killani. You always are generous when you introduce me. I feel privileged to be part of this, and I thank FICCI and the organizers for also accommodating me in this prestigious session. So Dr. Killani, as always, has given me a difficult talk, which is to look at drug therapy for mild COVID-19. And there is some amount of evidence and some amount of consolidation of drug therapy with regard to moderate and severe COVID-19. But for mild, we are still in early days. Anyway, it's a challenge and I will try to do my best. What we know is for mild COVID-19, patients are advised rest. They are advised to stay at home or institutional isolation, advised adequate fluid rehydration to ensure that they are not dehydrated, adequate monitoring with pulse oximetry as well, and get help promptly, paracetamol for fever, keep away from others, especially the elderly and those with comorbidities. Then in terms of home isolation, separate bathroom, bedroom utensils, cough etiquette, hand washing, cleaning of surfaces, wearing mask over the nose and mouth. This is what you would see as recommendation for people with mild COVID-19. But with regard to drug therapy, I will take you through what people have recommended, have used, what evidence is available, and I will leave it open for the discussion, which promises to be very informative. So the chloroquine was endorsed by none other than the president of the USA, arguably the most influential man in the world, along with azithromycin, of course. So, and that became the default treatment for COVID-19 without much evidence in the early days. Gradually, trials started to be reported, including randomized controlled trials. And among all that, I think the one study with good design as well as RCT is the recovery trial, and that compared all the available treatments at that time: antivirals, chloroquine, dexamethasone, azithromycin, and convalescent plasma was subsequently introduced, and so on. So this is a busy slide, and I don't want you to try to look at this, except I put it only to show you that there was a large pool of patients, 1,561 on chloroquine arm and 3,155 on the usual care arm. So it's a very robust study. And this is the outcome with regard to chloroquine. So if you look at the red line, which is chloroquine as against usual care, you find that these lines are very close together. When they are close together, you know that they are not different. If at all you find some difference, chloroquine is slightly worse than usual care. So at least you can say that chloroquine did not prove to be effective in this study. So in terms of evidence, I think chloroquine slipped down with this study, and so within 10 days, the US FDA revoked the authorization it gave for emergency use of chloroquine.
Now, corticosteroids. So this is, we are again very familiar with the recovery study, which I showed you just now. Recovery study substantiated the role of corticosteroids in moderately and critically ill patients. And the strength of this study also rests in the fact that it used a cheap and easily available agent, which is dexamethasone. Now, this, what I'm showing is a more recent study. It is a meta-analysis of about 7 studies done, including recovery study, looking at the overall efficacy. And this is the line to the left of which means it favors steroids. To the right of it means it favors no steroids. And you can see that each one of these squares or diamonds represents a study, and all of them lie on the left side of this line, which means all of them showed favorable response with steroids. So that is very clear. Now, my job is to look at the role on mild disease when no oxygen is required. So in this cohort, I go now back to recovery study. So this is the data. The recovery study looked at different subgroups. They looked at the mechanically ventilated. And this is the outcome in mortality of patients on dexamethasone. This is of usual care. And you can see that dexamethasone was clearly superior to usual care. Those requiring oxygen, again, dexamethasone here, usual care, again, dexamethasone superior to usual care. When it came to no oxygen required cohort, this is usual care and this is dexamethasone. In fact, dexamethasone fared slightly worse. In other words, if you give dexamethasone to people who have mild disease, the outcome could actually be slightly worse. The WHO guidance for use of corticosteroids, they said for use in severe and critical disease, strong recommendation. And there was a little bit of a kind of evidence that perhaps it should be used after 7 days of onset of treatment, but the data was not substantial to confirm this. And so they concluded that administering corticosteroids when treating severe and critical disease, even within 7 days, it should be done. And to err on the side of not giving corticosteroids when treating patients with non-severe disease, even if it is after 7 days of onset of symptoms. So the bottom line is moderate to severe disease, don't worry about how long it is after onset of symptoms, give steroids. And of course, it implies that for mild, do not give steroids. And of course, we know that corticosteroids has adverse effects, including things like strongyloides stercoralis hyperinfection, and these are endemic infections in countries like ours. Then thirdly, anticoagulation. It has been clear from the beginning that thromboembolic events are more frequent in patients. This is data from Europe showing that 7.7% of patients admitted in the ward and 16.7% of patients admitted in ICUs had thromboembolic disease. Therefore, I think there is standard recommendation, and we use standard intensity prophylaxis for all patients who are hospitalized. So this is the dosage schedule. I'm not going to go into it in the interest of time. And there is no data to inform risk of VTE in non-hospitalized COVID patients. So patients at home, as of now, there is no evidence, no recommendation. And what do you do when they leave hospital? Which is post-discharge prophylaxis need not be given routinely, but should be given in patients who have active cancer, previous VTEs, thrombophilia, sickle cell disease, D-dimer, high. So all these should alone have continuation of prophylactic treatment even after they get discharged. Now, favipiravir, it's an oral antiviral approved for treatment of influenza in Japan. It selectively inhibits RNA polymerase, which is required for viral replication. It was studied in Ebola, and there were some encouraging results towards survival benefits. However, at the end of the study, the benefits were not conclusive. So as we speak, we cannot say that it is a proven drug for Ebola. Japan has commenced phase 3 trials, as also US and of course India. So I'm going to show you two studies which are perhaps important for us. This study was done from China. It is an open labeled, non-randomized study. So please notice it's a non-randomized study and therefore the strength of the study drops. It compared favipiravir with leponavir and ritonavir. So those of you who have been following drug treatment of COVID will know that in one of the well-conducted studies, leponavir, ritonavir did not show benefit. And both groups received interferon alpha. Now, 56 patients were screened and 35 met eligibility criteria. Compared to leponavir, ritonavir, favipiravir had a shorter mean length time for viral clearance. So they cleared in 4 days versus 11 days with leponavir, ritonavir, which was statistically significant. And also they cleared CT shadows faster, or at least improved shadows faster or more, 91.4 versus 62.2, again statistically significant. And they had lower incidence of adverse effects, 11 versus 55%. So the only problem is that the comparator arm is not placebo, but another group which is probably not efficacious. Now, this is a study done from India. That's why I picked this up. 150 patients randomized to favipiravir and standard of care. So this is the dosage. Now, the primary endpoint is not clinical. It was, they received nasal swabs every day, and two consecutive swabs was the primary endpoint. And so the results showed that there was 28.7% faster viral clearance in the favipiravir group, which is 5 days versus 7 days in the control group. And 2/3 of favipiravir treated patients had viral clearance in less than a week. And 70% on favipiravir clinically cured by 4 days versus 44% in standard care. So this is a subjective clinical assessment. So what is the drawback of the study? It is an open label study, which means the patients and the doctors knew who received favipiravir. Therefore, what is required is a larger, well-conducted, double-blind randomized control trial. Ivermectin. It's a repurposed anti-parasitic drug, widely available because it is included in WHO list of essential drugs. It's an inhibitor of COVID-19 causative virus in vitro. In fact, there's a 5,000-fold reduction in the virus in 48 hours in cell culture. However, the criticism has been that to reach the level of concentration that the cultures used, you have to give several folds higher dose than what is given. So people have been looking at how to modulate this and use it more effectively. So recent meta-analysis indicate that high-dose ivermectin has comparable safety as low dose, which means that we can escalate doses much higher. Studies are already ongoing, and I'm sure more studies will be done, and we will have better evidence of the role of ivermectin in COVID-19. Convalescent plasma. I understand there are people that are not doctors on this forum, so convalescent plasma is the liquid part of the blood after separation of cells. It differs from sera in that it contains the clotting factors. It is obtained from donors by plasmapheresis, and then it is transfused to patients. So the rationale is that the patients receive antibodies, which people who have had the disease will have, and the hope is that these antibodies help patients combat the disease. There is evidence of its role in SARS-CoV disease in 2003, as also MERS disease. Now, in COVID-19 also, there are trials. These are some of the trials. There are unfortunately no conclusive results, but the trials show some benefit. So the last is yet to be said on this one with regard to evidence. The studies are ongoing in India, and we are yet to see the published report of convalescent plasma, although a preliminary press release said that it is not effective. So we have to understand that it can be given pre-exposure, post-exposure, early, moderate, severe infection. Now, almost all studies have largely given in moderate and severe infection. So with early infection, pre-post exposure, there's not hardly any evidence. So that is a field that is open for further exploration. Having said that, we have to understand that this is not completely without risks. There are known risks such as transfusion reaction and infectious diseases that can get transmitted. And there are theoretical risks like antibody pro-inflammatory reactions. We know that inflammation plays a very crucial role in the impact of COVID in the lung particularly, and the severe disease, which is often fatal, is more pro-inflammatory than the effect of virus itself. So these are the things that need to be kept in mind. Thank you very much.
Thank you, Dr. DJ, for an amazing presentation. I can understand there would be some overlap between the next presentation. So I'm sure Dr. Rajadhar will take care of that. And now it's my pleasure to invite Dr. Rajadhar to tell us about drug therapy for moderate disease. Dr. Raja, all is yours. Please unmute yourself. Yeah, you are there.
Thank you very much, Dr. Khilani. Thanks for the invite, and thank you to the entire FICCI family for inviting me to this meeting. So like Dr. Khilani said, there will be some overlap between what I'm going to say and what Dr. Christopher has said. But I think that's actually a good thing because it will emphasize some of the important points and the areas of overlap there is between mild, moderate, and severe disease. So just one declaration that this is a website all of you can use. There is a permission that's there from clinicaloptions.com, but these slides are for public display and for use. And please, I have used some of these slides, but I also tell you to go to this site and look at these slides. They get updated every 3 or 4 days, and you would get updated information about COVID-19 if that's an area which interests you. So let me talk to you about medical management outline, and we'll start from moderate and severe disease. And I'll start off in a manner which is similar to what Dr. Christopher did. So when you think about medical management of moderate COVID-19 infections, in the management part, you would monitor closely, even more closely than what you would do in mild disease, because at this stage, some of this population of patients might actually rapidly progress. And there are certain markers, and maybe Dr. Khilani will bring that out in the panel discussion, markers which predict patients who might progress more as compared to others. The question about antibiotics, I'll actually address here rather than later. So there's too much of empiric antibiotics being prescribed in patients with COVID-19. We know this is the viral disease. However, there are certain indicators which might tell you whether there is a co-infection or a secondary infection in these people, and reevaluation on a daily basis, making sure there's no new signs of infection, and de-escalation if the signs of infection go away are important parts of antibiotic therapy. The other important part which Dr. Christopher spoke about is most of these patients with moderate to severe disease are going to be in hospital. So hospital infection prevention measures, limiting number of healthcare workers, number of individuals who enter the room and meet the patient need to be minimized as far as possible. If possible, especially when there's high viral load, use of airborne infection isolation rooms and the staff wearing appropriate personal protective equipment is something that needs to be done. Dr. Christopher spoke about home versus healthcare facility. From moderate onwards, obviously the number of people who stay back at home is going to be less than the number of people who get hospitalized. However, it's very important to provide supportive care at home if these patients are for home isolation, and identifying the vulnerable household contacts and identifying high-risk deterioration patients is important, and here hospitalization would be preferred. If you're home isolating, investigations become a challenge, and that's throughout the country. However, if moderate patients come into hospital, some of the investigations as a part of initial evaluation is on that slide in front of you. So the chest X-ray in a small minority of patients, CT at presentation, and ECG, and maybe we'll speak about COVID-related heart changes later on in the panel discussion, and then doing blood parameters, the complete blood count to look at the neutrophil lymphocyte ratio, CRP, looking at liver renal parameters at baseline, looking at D-dimers and so on, are all very important. And on similar lines, when you think about the overall medical management of severe COVID-19 patients, these are patients who will definitely be in hospital. Hence, monitors to look at these patients on a regular basis, making sure that there's enough of oxygen and oxygen delivery devices, trying to look for emergency signs, both from a nursing and a medical perspective. And we know this is easier said than done in the COVID era when people are wearing PPE and there's a mortal fear about looking at patients. So these signs, emergency signs, become more challenging to pick up in the COVID era as compared to what they used to do before. The saturation is very important, and Dr. Christopher touched on that. The fact that saturation of less than 94% is worrisome, and saturations of less than 90% is where the penny drops and patients move from the moderate to the severe category is important. There'll be about 5% of patients who will have a co-infection. And it's important to try and identify these individuals because that's the group of patients where empiric antimicrobials in admission becomes extremely important. Sending the cultures off become very, very important. So let's look at each different facet. I'll spend just a minute on oxygen therapy because I think that's going to be covered in the next talk. But I need to show you this one slide, which is actually dated and predates the COVID era. But this was a large RCT, multi-center but open label trial, which looked at patients in 3 arms. So patients who were just on oxygen, patients who were on non-invasive ventilation, and patients who were on high flow nasal oxygen, which is one of the more modern methods of delivering oxygen to patients who have a low oxygen level, as in are hypoxic. So they looked at patients who had low oxygen below 90%, which is measured by something called the PF ratio, and the cutoff for this PF ratio was less than 300. And to cut a long story short, they found that the intubation rate in these 3 categories, so patients who were on oxygen, patients who were on non-invasive ventilation, patients on NIV, the rate of intubation going on to mechanical ventilation was similar, or even though there was a trend to less intubation in patients with high flow nasal oxygen. However, what's interesting is looking at how many people survived at 90 days. And at 90 days, in these patients with low oxygen levels, patients on high flow nasal oxygen did better, as in survived more, as compared to both patients who were just on oxygen or patients on non-invasive ventilation. And a lot of this data is what's been extrapolated in treating patients with COVID-19 when they're hypoxic, when they have low oxygen levels, which is why high flow nasal oxygen is something which has been emphasized on in the management of patients with severe COVID-19 infections. Again, Dr. Christopher spoke about anticoagulation, and I'll touch on this too. This is a slide which looks at the various trials looking at the burden of thrombosis, so the burden of formation of clots in patients with COVID-19. And you can see various trials on there, but I want you to look at the right-hand corner, which says VTE rate. So these are patients who have had clots while being on treatment. A lot of these patients look at thromboprophylaxis. So this is patients who were on treatment to prevent clots, and you can see a fair few. So except the first one, all the other patients were on treatment to prevent formation of clots. And in spite of that, a mean of 20 to 30% of patients ended up getting clots, which is why the worry of thromboembolic disease, the worry of clots in patients with COVID-19 is so profound. So how do we actually screen these patients? And this looks at various parameters which predict the risk of thrombosis in COVID-19. So you can see D-dimer at the top. I want you to look at D-dimer. I want you to look at CRP, and I want you to look at ferritin, because a lot of you would have heard of these parameters being checked on a regular basis in patients with severe COVID-19 infection. And you can see with D-dimer, be it the initial result, be it the lowest level of D-dimer when you're doing it repeatedly, or when you look at the maximum level of D-dimer, again, when you're doing it repeatedly, all of this predict the risk of thrombosis the best out of all parameters. However, CRP, which is a blood marker we do often to look at infection levels in the body, is also a close second in measuring the risk of thrombosis. And again, ferritin is a lesser marker. It's less useful, but is useful in measuring the risk of thrombosis. So I want you to remember these three as carry home messages: D-dimer, CRP, and ferritin. Out of this, D-dimer is the best, but all of these markers tell you about the risk of thrombosis. The other question that needs to be addressed is when you're giving these patients blood thinners, you're giving these patients anticoagulants, do you give them at the preventive dose, as in the prophylactic dose, or do you give them a therapeutic dose, as in the treatment dose? And you can see this observational study, which looked at prophylactic versus therapeutic. And to cut a long story short, it shows the in-hospital mortality was greater with therapeutic as compared to prophylactic. But we need to understand that in this observational trial, the patients who went on to therapeutic anticoagulation, therapeutic blood thinners, were at a much poorer cohort of patients, a much sicker cohort of patients, as compared to the ones who were on prophylactic anticoagulation. And that might explain the greater mortality in patients who were treated with blood thinners as opposed to prophylactic. So what's the approach to thromboprophylaxis? And this gives you the gist of various institutions and what they think about prophylaxis versus treatment. I won't go through the entire slide. You could look at this slide in your own time, but let's take number one. So if you have a D-dimer level, which is less than 500, so low normal, you would give these patients a preventive dose of anticoagulation, a prophylactic dose of anticoagulation. If your D-dimer level was between 500 to 2000, you would individualize treatment and maybe look at other markers and risk factors for clotting in that individual and take an individualized decision in that group of patients. But most of these patients will also go on to preventive anticoagulation. If you look at therapeutic, so patients who have a D-dimer of more than 2000 are the ones where you would put these patients on treatment dose of blood thinners. And there are other approaches on that slide which look at preventive versus treatment dose of anticoagulation on similar lines. I show you this slide, which a lot of you would have seen before. So start of COVID-19 infection, you have viral replication, and then over a period of time, the viral replication peters off, but the host inflammatory response, the immune response of the individual gradually goes up. And in accordance, when you start off with viral replication early on in the disease, you have mild symptoms, a fever, a dry cough, etc. And then as the host inflammatory response goes up, you have more of breathlessness, reduced oxygen level, and later on in the illness, you have respiratory failure, you have heart failure, you have shock-like features, and so on. So the drugs that Dr. Christopher spoke about, the antiviral, he spoke about favipiravir. I'll speak about remdesivir, which is the antiviral here. The steroid that he spoke about and the oxygen therapy he spoke about all start off more or less at the same point. When the viral replication is gradually coming down, the host inflammatory response is mounting, and patients start dropping their oxygen levels gradually, their saturation levels gradually. That's when these agents actually come in and become useful. So let's talk about the antiviral quickly. So remdesivir is the antiviral that's been used. That's what the FDA emergency use authorization, which got published sometime in May, says. It says permits the emergency use of an unapproved product remdesivir for treatment of suspected or lab-confirmed coronavirus disease 2019 in hospitalized adult and pediatric patients. And this gives you the various doses. I won't bore you with going into details of that, but suffice to say that this drug has a loading dose and then a maintenance dose and can be given to adult and pediatric patients. You give it for a minimum of 5 days and a maximum of 10 days. And the data shows giving it for 5 days versus giving it for 10 days does not make a lot of difference as far as the response is concerned. So a global perspective on remdesivir, you can see there's various countries which has come up with recommendations for remdesivir, which are all positive. And this drug has probably got the maximum evidence as far as antiviral treatment in COVID-19 is concerned. The next drug I'm going to talk about, again, something Dr. Christopher spoke about, is dexamethasone. So this is a corticosteroid a lot of even non-medical colleagues on the forum today would know about. It's used to treat various conditions, and you can see some of them on that particular side. It can be given intravenous or oral, and it can even be given in pregnancy with a slightly higher risk profile. So this is the recovery trial with Dr. Christopher quoted, and in this, the patients who were on dexamethasone and requiring oxygen or requiring invasive mechanical ventilation seemed to do well on the steroid at a dose of 6 milligrams per day for a total of 10 days. However, like he said, patients who were not requiring oxygen did not do well. And this is what we mean by doing well. You can see the brown line and the blue line separating there. The brown line is the patients who are on dexamethasone. The blue line is the one patients with dexamethasone, and the brown line is usual care. And you can see mortality is greater in usual care versus patients who are on dexamethasone. And in patients who are on no oxygen, you can see the separation is less. It does not reach significance. Treatment with steroids do not seem to reach significance. This is another part of the recovery trial, which also looks at patients with invasive mechanical ventilation. And you can see a larger separation with dexamethasone in patients who are invasively mechanically ventilated. So mortality at 28 days on patients on steroids is lesser in patients who are invasively mechanically ventilated or patients who are hypoxic. I'll very briefly allude to human convalescent plasma. So this is what Dr. Christopher spoke about. You have a donor there who is actually recovered from COVID-19, who has the antibodies, the neutralizing antibodies in the blood. The blood undergoes apheresis. You separate the plasma. The plasma gets given to the patient with COVID-19. And like he said, there's been various trials, even a meta-analysis looking at convalescent plasma. But unfortunately, the conclusion of these trials is that there's no statistical improvement at 28 days in these patients. However, there's this one study from the Mayo Clinic which tells you patients who might benefit. So early starting of convalescent plasma, that's one. And second, patients who have a higher titer of antibody in their plasma seem to have a benefit from this agent. Hence, it should not be a routine part of care. However, in certain patients, it might actually help. So that's my concluding slide and your carry home messages. The fact that oxygen is important and oxygen delivery devices need to be thought of in patients with COVID-19. Anticoagulation is important and it should be given in all hospitalized patients, and whether it's preventive or whether it's therapeutic is important. Remdesivir is an antiviral, is important in severe disease, but even in moderate disease, it's coming into consideration. Steroids are effective in patients requiring oxygen in any form, and convalescent plasma is still questionable, but might be useful in certain category of patients. Thank you very much for listening.
Thank you. Thank you, Dr. Raja. As always, amazing presentation. Now, may I request Ms. Aarti or Dr. Ms. Upasana to please put presentation by Dr. Inder Puri from
Ankur Puri, yes. Malika, can you please do that?
Gaurav, could you please put on the video? Just to let everyone know, just a second, Gaurav. Dr. Ankur Puri has also prepared a presentation. Unfortunately, the platform does not permit us to play both the PowerPoint and the video. So we'll put the video on and we'll be circulating the link of his presentation to all delegates, and we will be publishing it on our website dedicated to FICCI Heal. Gaurav, please go ahead. The title of his video is COVID-19 and ICU Perspective.
Good afternoon, I'm Ankur Puri. I'm a pulmonary critical care and sleep physician at the University of Pittsburgh Medical Center. I've been asked to speak today on the specific considerations for COVID patients. particularly in the ICU setting. So we will delve straight into that because time is limited. The role of the critical care physician is to be the team leader whose responsibility it is to not only take care of the patient that's in the ICU, but also in case of infectious diseases like COVID-19, to take care of the team, the healthcare workers that are deployed in the ICU. With that in mind, there are certain specific things that we've planned, and this is something that's been evolving over the last 6 months in our ICUs, from starting out with negative pressure units to going to negative pressure rooms to general population habitat for some of these patients admixed with other ICU patients based on what the prevalence and the resources that were available were. Appropriate personal protective equipment is very important. Appropriate dress codes where you're trying to keep arms below the elbow bare, no ties, no scarves, no lab coats on the unit, things like that. And again, infection control helps develop these protocols to quite an extent. But the general principles are to avoid patient contact as much as possible wherever it is safe by minimizing lab testing, imaging, by utilizing once a day medications or continuous infusions versus multiple day drugs, minimizing visitors, certifying realistic expectations from patient and family regarding cardiopulmonary resuscitation, minimizing travel outside the ICU unit, and minimizing procedures that require aerosols. The other thing that we can talk about today are certain complications that we see and how we adjust management for those for COVID patients. The first thing that we'll talk about is what's very widely known, which is respiratory failure, which this becomes a big impact thing for COVID patients because the respiratory system is what affects these people in most cases. Oxygen requirements may be nothing in some patients and may rapidly escalate, typically usually during week 2 to require high flow nasal cannula circuits, face masks, intubation. Early on in the course of the disease, 6 months ago, let's say, we had a much lower threshold for intubating patients because the concern was if the patient were to deteriorate in an unplanned manner, the potential for exposure to the healthcare team would be much higher. As we've gotten to develop protocols, the threshold for intubation has gone up significantly, particularly with some studies that showed that once a patient is intubated, the mortality is much higher. The etiology of respiratory failure is again multifactorial as far as we understand, from viral bacterial pneumonitis to an ARDS, diffuse alveolar damage kind of picture, and then in situ thrombosis and pulmonary emboli as part of this whole hypercoagulability profile that COVID-19 patients tend to have. Awake proning is something that general public and a lot of non-pulmonary, non-ICU physicians weren't aware of before COVID-19, and early data suggested that it does stabilize oxygenation and improve oxygenation. And we've used not only awake proning, but also proning in conjunction with mechanical ventilation in a number of patients. If the patient does require intubation, then forming intubation teams, having checklists, having rapid sequence intubation, all of these things designed to minimize aerosol exposures is very important. But we're getting more and more comfortable using non-invasive ventilation, heated high flow circuits, and avoiding intubation as much as possible in a lot of these patients. Another thing to remember is extubation. So somebody who's intubated, removing them from the ventilator is also highly aerosol generating. So care has to be taken during that time also. And let's talk about shock for some. And there was quite a bit of talk about that with myocardial depressant action of COVID-19 and myocarditis from COVID-19 also being talked about. Then with the whole thrombotic picture, there is the increased incidence of myocardial infarction. And also there was talk about the cytokine storm causing a vasodilatory shock. But in general, shock tends to be of mixed etiology. Pressors, but before pressors, volume management with crystalloid boluses becomes the mainstay of that mainstay of management. A small number of people may require high dose steroids. Indications for steroids have been talked about in other talks, so we will not go into that. The other thing pertinent to the ICU is the development of acute kidney injury and renal failure. Again, could be multifactorial based on volume management, based on vasodilation, based on renal perfusion. And we do know that people that develop renal failure do tend to have a higher mortality. Continuous renal replacement therapy, CVVHD, CVVH tends to minimize staph exposure because they're continuous rather than intermittent, and that's something that should be considered. Talking about the hypercoagulability quickly, both arterial and venous thrombosis incidents are increased in people with COVID-19. There was a recent study that showed that in older populations, in males, in people with pre-existing CAD, and people who presented with an elevated D-dimer at presentation, the incidence of thrombosis was higher. Arterial or venous thrombosis may be, when present, are associated with increased mortality. Optimal management strategies are still not known. Studies are currently ongoing as to the drug of choice, duration, and the intensity of anticoagulation. But in general, being aggressive about prophylactic anticoagulation in ICU patients is very important. And there may be a select subset of patients that may benefit from therapeutic anticoagulation. Secondary infections are common in COVID-19 patients in the ICU, particularly given that people that have respiratory failure tend to have it for multiple weeks and they're in the ICU for a long time. Empiric antibiotics, culture-based antibiotic stewardship, and de-escalation of antibiotics is things that we talk about from proper antibiotic stewardship are all things that should be looked at. And I'm going to stop there as my time is up. Thank all of you for this opportunity to speak. Stay safe, use a mask, socially distance, and perform hand hygiene. Thank you.
Thank you. Thank you, Dr. Puri. I'm sure your words of wisdom about critical care will go a long way in helping everybody who is involved in the care. So we move forward. So we go on to a panel discussion, which will be case-based. And as I said, I have an amazing panel with me. So I'll start with the case straight away in the interest of time. We have 35 minutes to So these are the panelists. I've already introduced to them. So this is a 40-year-old male with no comorbidities. He presented with fever for 4 days, cough, sore throat. He had fever with the tachycardia. Blood pressure was normal. Blood pressure, respiratory rate was also normal. Saturation, which everybody is monitoring today, was 96%. chest examination was normal. He had a normal hemoglobin and normal TLC count. Lymphocyte count was 22%. So an X-ray chest done was normal. So since he was in a higher socioeconomic status, we also did his CRP was normal, D-dimer was normal, ferritin was normal, LDH was normal. So was the X-ray. So he has a mild COVID infection, which is extremely common. So we'll be talking about a few questions which I'll be showing, and then I'll be coming to my panelists. I'll request all of them to please unmute yourself. What medication should be started? Should biomarkers be done, and how frequently, if at all? Should CT be done? Indications for doing an HRCT, and what should be the parameters for follow-up? I'm not going to repeat what we have already discussed, and there could be various modalities. You give HCQ with azithromycin, HCQ azithromycin with favipiravir. You could give HCQ with doxycycline. You could give ivermectin with azithromycin. Variety of combination. You could give ivermectin, doxycycline, and favipiravir. So now we know that an role of favipiravir has been already been discussed. Now with these questions on board, Dr. DJ already dumped hydroxychloroquine, but ICMR and DCGI have recommended hydroxychloroquine. If I don't write hydroxychloroquine to the patient, sometimes I can be questioned. And when I write hydroxychloroquine, I look at it, the patient might ask me what is the toxicity. I have got hypertension, I've got a stent. Dr. Claire put it few years back. So Dr. Claire, I come back to you. Please unmute yourself. So, yes, sir. So my question to you is, how a physician, lay physician like me, advises patients as to whether he should take hydroxychloroquine and what is his risk?
Right. The hydrochloroquine, one of the cardiac toxicity is the QT prolongation. And if you have a QT prolongation, then you can develop ventricular fibrillation, which we described as torsade D pointers. It's a VT with which goes on shifting the axis. So before we give hydrochloroquine, we must look at corrected QT interval, QTC. Now QTC, there are formulas available, but if you don't have that kind of formula with you, then it is a QT interval divided by RR interval in milliseconds square root. So there is a way to calculate it. If it is normal means 430 milliseconds for men and 450 for females, then there is no problem. Go ahead and give hydrochloroquine. But if it is less than 500, you can still give hydrochloroquine with caution, but we need to observe these people. But if it is more than 500 milliseconds, then it should be valid as far as possible. Unless there is a real benefit expected, then these patients have to be admitted and their rhythm has to be monitored. Another thing is that if you want to give hydrochloroquine, please see that this patient should not have electrolyte abnormalities like hypokalemia, hypocalcemia, because those are independently known to produce QT prolongation, like azithromycin. If you give azithromycin, that also prolongs QT interval. So combination is much more dangerous as compared to hydrochloroquine alone. So it's basically the QT interval, the corrected QT interval, which we need to monitor.
So Dr. Claire, Dr. Claire is only one. We don't have your clones. With 60 lakh cases of and more of COVID in India, doing ECG and measuring their QTC interval. So are there some people where you don't have to worry about QTC? Just give hydroxychloroquine as we are doing.
Well, patients, who are not on any drugs and who are not dehydrated, who don't have clinical evidence that they can be hypokalemic, and they're relatively young, they are not taking other cardiac medicines.
Like you are young. So what would you say? What is young?
But I think a minimum requirement is ECG. We must take the ECG before we start hydrochloroquine in this patient.
Suppose, okay, this patient is 40 years old. He has no comorbidities, he is not hypertensive, no family history of cardiac element. Can I give him hydroxychloroquine without doing an ECG?
Absolutely, you can give. Yeah, there's no.
So that's what my question was. So if I could rephrase my question, which are the patients where you would mandate an ECG before giving hydroxychloroquine?
Yeah, I think patients who are more than 60 years of age, patients who are on some cardiac medication, patients who have some degree of heart failure, patients who are already taking any other medication, not only cardiac medicine, even some other. See, in medicine, all of you will agree that it's a principle that we must know what are the medicines, total medicine a patient taking before give some other medication. So we need to look into the interaction of those things.
Okay. Sir, another question that frequently we are giving azithromycin, and azithromycin is also known to cause QT prolongation. So what is your comment on that?
Yeah, absolutely. We have seen, I have seen myself cases coming with the Torsad, because a young fellow, somebody gave azithromycin and they come with Torsad pointers. So whenever you give azithromycin, you have to be careful about that. And in the COVID era, for example, because this combination was advised for many patient treatment, if you want to use combination, then I think it is much more important to be careful about the.
Thank you, sir. Thank you for your words of wisdom. Now I come to Dr. Chabra, astute pulmonologist. I gave you 5 choices of therapy for your patients, 40 years old male. Dr. Chabra, what will be your choice? You go by alternate, or you have fixed choice that you will give this treatment?
See, this patient is a classic example of a mild COVID disease.
Yes.
No comorbidity, he is not at risk of worsening. So I will give supportive treatment to these patients.
No, talk about pharmacotherapy. Our mandate is pharmacotherapy.
See, I have been managing these patients at home with the precautions and no antiviral, the so-called antivirals. Because what I feel is that the kind of support these have enjoyed among doctors is not, supported by the evidence. Ivermectin, people are using different doses, but the dose that you require is far greater.
Right? Dr. Chabra, my question is very straight. Patient has come to you. What would be your therapeutic prescription?
Only paracetamol and supportive treatment. Okay. No HCQS, no favipiravir, no ivermectin, no doxycycline.
Dr. Raja, your answer. One word answer. Unmute yourself, please.
Sorry, Dr. Khillani. So I would actually give this patient favipiravir, and sort of 2-word answer is that I think if you start the antiviral early and
viral application, I just need an answer in the interest.
Favipiravir with whatever else Dr. Chabra said.
No hydroxychloroquine, no azithromycin.
No hydroxychloroquine, no azithromycin.
Yeah. DJ, please unmute yourself. DJ.
Yeah.
One word answer.
One word answer. Okay. So I actually would go with Dr. Chabra. I would only give supportive treatment.
Anjan, please unmute yourself.
I'll go with Dr. Chabra.
Okay, all right. So very good. So there's a consensus that loads of prescription that we are saying is. So next question is that how would you monitor these patients as far as the biomarkers is concerned? I come to Dr. Chabra.
Personally, in this patient, I would only advise him to watch his temperature. Usually in mild patients, after 3-4 days, the fever should subside and the disease should gradually go away.
No. Right? The question is, you see, he's not living with you. He's saying that after how many days should I come to you? Should I do any tests?
Yeah, so I'll advise him to monitor. If on the first visit, no testing, no use of markers in the first 2-3 days. Now, if on monitoring his fever has not subsided after 5-6 days, or cough is increasing, or he's having shortness of breath, and most importantly, if the pulse oximetry is showing a decline, then this is a patient who is going to a more moderate stage of disease. So that is where these patients have to be caught
and these patients would require hospitalization.
Dr. Anjan,
Short
please
of
unmute
medical
yourself.
costs.
Yeah, I got your point. Dr. Anjan, this patient asked you that I live near Mahajan Imaging Center. I want to get a CT done.
No, I think just because he lives near Mahajan's center doesn't indicate a CT. Okay. You have yourself said in your presentation that this patient was powerful and something was done because he was rich and powerful. So let us leave that thing out and let us go on scientific facts. He doesn't need a CT at this time.
At this time, it doesn't need a CT. Okay. All right. So we'll go proceed with the case. I'll start sharing the screen again. And so the consensus is that one panelist says the favipiravir, there is no favor for hydroxychloroquine, doxycycline we didn't discuss, ivermectin, all we have been discussed. In the interest of time, we move forward. And so the above case, after that he came back. He had high grade fever for last 8 days. His cough was persisting for 5 days. He had a little bit of breathing difficulty for last 2 days. So when we examined him, he still was febrile with tachycardia. Blood pressure was slightly lower. Respiratory was 30. His SpO2 was 88 on room air. Bilateral air entry was good. No other abnormalities. Central nervous system was normal, and ABG showed hypoxemia, PaO2 of 56 millimeters of mercury. So this patient is now admitted in COVID ward, started on oxygen, 6 to 7 liters. Investigation showed that CRP was 97, D-dimer was 1800, ferritin was 778, LDH was 540. He started on steroids, anticoagulation also, and CT chest of this patient showed these pictures. And as you could see that, he has, even with the blind eyes, you would say that this is COVID and nothing else. Ground glass opacity more in the periphery, little denser in the lower lobe. I need not describe. I'm not a radiologist, and that's not a topic of discussion also. So I come to you, Dr. Anjan. Oxygenation. He is hypoxic, is requiring 6 to 7 liters of oxygen. So how would you give him oxygen?
Okay, he is hypoxic. He is on a 5 to 6 liter of, let's say, a face mask. If he's doing well, I would really don't do anything. If we are able to raise his saturation above 95 or let's say 94, but then various modalities are available, we would have a high flow nasal cannula around the corner other than the non-rebreathing bag or an NIV. There would be patients who would do better with an NIV as compared to HFNAC, or we will try to alternate with them. What is more important here is with oxygen, even with 4 to 5 liters, I will ask him to lie prone.
Okay. So suppose if you were to choose between high flow nasal cannula and NIV, what would be your take on that?
See, my take on that is that high flow nasal cannulas with a nasal cushion, patient is slightly more comfortable. Claustrophobic feeling with the NIV is not there, depending upon what kind of interface you use. Helmets and full face masks are a bit tough. If you have only a nasal mask, patients may do better. But what is important here is that with a high flow nasal cannula, it's easier for the patient to lie prone than with the NIV mask. And that's why it goes towards the favor of high flow nasal cannulas. After having said that, I must point out here that the requirement of oxygen would be about anything between 30 to 60 liters per minute, and your manifold rooms could go for a toss. They are going for a toss in many hospitals in India at present time.
Yeah, but Anjan, I have a little more intricate question for you. As an astute intensivist, are there any particular situations where you would prefer non-invasive ventilation as compared to high flow nasal cannula?
Yeah, if many of these patients are normally on if these patients are on, let's say, domiciliary BiPAPs and all those group of patients, they do very well on non-invasive ventilation with masks. They are so used to them, they are comfortable with them. And these are the group of patients where I would prefer this. Other point is I would prefer NIV when I have low supply of oxygen.
No, that you already said. But
yes,
let's expect that we have everything. So suppose are there any clinical parameters, something like if the patient you are seeing getting tired or he is worse
See,
off
yes,
breathing,
okay.
sorry,
I'll come to that.
let me finish.
Okay, sir.
Increasing or on ABG the PaO2 is 50 and CO2 is higher side of the normal. That means CO2 has started rising. What is that a point where you should consider long-range ventilation?
Yeah, I think that is the place where we need to keep that in mind, that if we have this kind of an ABG picture, then the patients would do better with an NIV if they tolerate it well. That is the time. That's why I said that you need to have both of these devices when you are trying to plan for oxygenation.
And is there a place for electively, alternately using BiPAP and high-flow-nasal cannula in the interest of patient comfort?
Yes, to be honest, most of our patients are doing better when we alternate both these things.
Yes.
One thing very important is that the skin marks which are left by the NIV masks are taken care of by high-flow nasal cannulas if you alternate them. But it is to be alternated only if the clinical picture allows us to do.
Okay. So any of the panelists have want to add into the oxygen therapy, or I can go ahead with Dr. Chavda, Dr. DJ, anybody else?
Just a quick perspective from our side. As was said, we don't use HFNC only because of the oxygen. It's such a oxygen hungry device. And we have found giving NIV in patients who require an FiO2 of about 40, above 40, or respiratory rate of more than 30, we start NIV, and we have seen excellent results, and many of them do not progress downward. So early use of NIV, we believe, reduces the work of breathing and therefore self-inflicted lung damage. And for us personally, I think that has been the comfort zone for us.
So yes, Raja, please.
So quick point. So I think the early start is the operational thing here. So I think with someone who's got a respiratory rate of 30 and is requiring 6 to 7 liters, be it HFNO, be it NIV, this is the point where you probably need one of these, depending on what the logistics allow you to do. But I think something needs to be started in this individual rather than just maintaining them on a face mask.
So Raja feels earlier intervention. Yes, Chavda. Dr. Chavda.
Fortunately, these patients are not very dyspneic. Most of them we have found are not very dyspneic. So we find that non-breathing mask with reservoir, that is also a very useful system in these patients.
Sure. So I totally agree with you. You can give higher FiO2 with this. Now we talk about we have talked a lot about corticosteroids. So the 3 questions which are put here, I need not repeat. So Dr. Chavda, dexamethasone, hydrocortisone, methylprednisolone, what is your choice?
I would go with whatever is available.
No. You have, please. That's the political answer. Give a precise answer.
Dexamethasone.
You have everything on the earth with you.
Dexamethasone.
Eh? Dexamethasone. Any opinion to contrary?
So I think the reason the recovery trial used dexamethasone is because methylprednisolone is not available in the UK. So we are more comfortable using methylpred, and if we have to give something IV, we would give a lower dose. So something like 40 once a day or 40 twice a day of methylpred is what I would use. And there's been one observational trial from India published recently showing that 40 milligram once a day of methylprednisolone and 6 of dex have an equal effect in patients with COVID-19. So that's an option. Dex is fine, but I think you could also use methylpred.
Yes, Anjan.
From the very beginning, from 3rd of April, when we got our first case, and now we have about 2,000 with us in the center, it has always been methylprednisolone, 1.5 to 2 milligram per kg, depending upon the patient, and we've done very well. There are also certain reports that methylprednisolone gets secreted a bit more in the lung epithelium or something of that kind. So we are comfortable with methylprednisolone and we use that. However, you could choose any after the recovery trial. I think
So
Dr. Chavda.
the recovery trial said dexamethasone 6 milligram, which is equal to 36 milligram of methylprednisolone and 40 milligrams of prednisolone and 160 milligram of hydrocortisone. So we are actually using more dose than the recovery trial. The meta-analysis which was shown by DJ And when I checked the odds ratio, the best results were with dexamethasone, followed by hydrocortisone, followed by methylprednisolone. You can check it. That's what the evidence is. My thinking is that we are using higher dosages than this is because we are in habit of more the merry. You know, we have used 1 gram of methylprednisolone as a pulse therapy. So in my unit, I have started using methylprednisolone in 1 milligram per kilogram body weight. And the next question is quickly, Dr. Chabra, when to use it? Suppose the person's biomarker, suppose the CRP is 15 and there's a bit of pneumonia on CT. Would you use, and the oxygenation is normal?
Well, the critical point is whether the patient is starting to develop hypoxemia.
नहीं नहीं hypoxia नहीं है, वही पूछ रहा हूँ.
So if the patient goes into a second week, so first week, mild patient, absolutely no indication for steroid.
Question is, patient has bilateral pneumonia, oxygen is 96%, CRP is 30, D-dimer is 600, will you give steroid?
Probably yes, because I'll go into the overall picture.
Probably yes. नहीं नहीं, तो answer बिल्कुल.
Yes, if it's day 8 and patient's fever is on, see, one has to assess the overall picture, right? Not just parameter.
So the Albert Einstein Institute study shows that if your CRP is more than 20, if you give steroids, survival is better. If your CRP is less than 10, if you give steroids, the mortality goes up. That message should be there. So we can't discuss everything here. So the last part about steroids is that they are very useful. They should be used in time. If the hypoxemia, there is no question. If the bilateral pneumonia is there and if the CRP is high or other biomarkers are high, Dr. Chabra, we'll have to go ahead. So I'm sorry.
One very minor point. Unfortunately, pulse therapy is becoming very popular.
We are not discussing what others are doing. We are only discussing. Now coming to the remdesivir. Dr. Anjan, I come to you.
Yes, sir. Yes, moderate cases, we use it. The loading dose was described by, I think, both Dr. Christopher and Dr. Dhar. We are using it. We are using it for 5 days. We were part of the solidarity trials. So it was initially 10 days, came down to 5 days, but now we're using it for 10 days on patients who are on ventilator. Obviously, there are issues about CKD, less than 30, that is different. But yes, we are using it, and I would advocate it to be used in patients who have moderate to severe disease.
So I've already discussed about steroids. Which sort of steroids we have already discussed. Remdesivir initially was approved for severe cases only, but subsequently this trial came, which almost 12 days back, where remdesivir was used in patients who did not have desaturation, but he had bilateral pneumonia, and it showed significant improvement with 5 days therapy as the. I need not go into the detail, and there was significant improvement on a 7-point ordinal scale, and that has changed our practice. That means if the patient has bilateral pneumonia and he is not having desaturation, still remdesivir has a value. Now we come to this particular patient was started on steroids, anticoagulation. I am just racing against time. So on 12th day, his heart rate became slow, and ECG shows sinus bradycardia with a QTc of 0.44. Cardiology opinion was taken as top T and 2D echo were normal, and this is how the heart rate went down. From day 1 when we started measuring, and then day 4 after admission. The question is, Dr. Claire, the king of cardiology, should we get worried about it?
Yeah.
3 questions for you. Should we be worried about it? Cardiac complications of COVID and sudden deaths are seen. How to prevent them?
Right. See, first of all, I was to tell you that in at least one of the studies from Wuhan, they showed that the cardiac arrhythmias were noted in 16.7% patients of COVID. These patients were all admitted, so they had at least moderate to severe disease. The common arrhythmias are tachycardia rather than bradycardia, but bradycardia does happen, as we have seen that patient, and I know which patient you are talking about. The another thing is that when patients who have got significant myocarditis or they develop heart failure, those patients are prone to get a ventricular fibrillation and cardiac arrest. So these are the kind of the arrhythmias which people have. Normally, if you have just a bradycardia, blood pressures are maintained, saturations are okay. We don't care if it's a sinus rhythm. It also depends if it's a sinus rhythm. If a sinus rhythm is there, for example, even the rate is 35, I will not do anything, just keep observation. But if it is the heart block, for example, then you should start worrying, and sometimes maybe we need a temporary wire to paste these patients.
So, sorry.
Yeah, another because I am speaking now. Another thing is that as far as the other complications of cardiac complications of drugs are concerned, we have talked about azithromycin, QT prolongation, the tocilizumab, the interleukin modifier. It causes hypertension. The other lopinavir and rotinavir, they can cause AV blocks. The other drugs, there is not much information of the cardiac effects. And patients who have got a cardiovascular disease, their mortality is highest. Actually, this parameter is the most important as far as mortality is concerned. Roughly 10.5% people with already pre-existing cardiac disease have mortality, which is, I think, very high. Raised troponins are very high, 5 to 25% of the patients. Again, this will indicate some kind of myocardial injury. So patients who had heart failure during admission of COVID because of the COVID myocarditis, they have a very high mortality, 52% mortality. Patients who were discharged from the hospital, only 12% had heart failure. So heart failure during admission of COVID is again a very, very important prognostic factor. And one question I would like to ask any one of the panelists is that I read somewhere recently that the red cell distribution width, it can be one of the prognostic factor. How, whether it is valid or not, I may like to ask any one of you.
Okay, that we'll discuss after this discussion is over. So my question is to you, sir. As a non-cardiologist physician, when should we test a patient for, say, CPKMB or troponin, or when we should get worried? Because sudden deaths are seen.
All the admitted patients, we should have CPK and troponin.
So that should be added to the care of the admitted patients.
Absolutely.
And this being a prothrombotic state, so people have reported, coronary events without having plaques. So do you think that prothrombotic state is leading to a higher incidence of ischemic events?
Yeah, no doubt about that. Actually, in COVID, there are the most important symptomatology, acute coronary syndrome, and acute myocardial infarction occurs because of two reasons. One is that you have a coronary artery disease already. What percentage, 60, 70 or 40, doesn't matter. So there is a clot formation over that because of the hypercoagulability because of the corona. So these patients, when you do the angiogram, you will find that particular vessel, the culprit vessel, being totally occluded. But then there are patients who come with ECG changes and chest pain, exactly like myocardial infarction, but do their angiogram, the coronaries are normal or very little plaques. So these changes are because of the myocarditis, severe myocarditis. So they can mimic a myocardial infarction.
So other question is, sir.
I think your question is that I think all moderate to sick patients, they need some kind of prevention against thromboembolism, pulmonary embolism also very common.
I'm coming to that, but I'm not yet finished. Sudden deaths have been common. Other thing is that there was a report of autopsy, about 85 autopsies were done, and they didn't find myocarditis. They found cardiomyopathy in the autopsy series. So do these patients are likely to get cardiomyopathy, dilated or whatever at a later stage? Is there any?
I am not aware of that study personally, but unless you do biopsy or histopathology on a larger scale, it will be difficult because any cardiomyopathy for that matter, cardiomyopathy as itself, most of the cardiomyopathies are a sequelae to some kind of myocarditis. Because we are not able to catch them in very early, and sometimes the history is even missing. Apart from the metabolic disorders like sarcoidosis or amyloid or some kind of granulomatous disease like tuberculosis, most of the other cardiomyopathies are perhaps sequel to some kind of myocarditis.
Okay. So now coming to the implication of what wisdom you have instilled. There have been patients who after going home, they have come back and they dropped dead on the way, and probably they had a myocardial infarction or they had pulmonary embolism. So, Dr. Chabra, what about putting them on oral anticoagulant or some kind of anticoagulation when they go home? So which patient and for how long? And what should be the parameters?
Very important issue, and we have to carefully select our patients because the risk-benefit analysis has to be done. Now, there are some patients who don't recover completely. They are on oxygen and they would not be very ambulatory, so they are at a risk of developing thrombotic complications. Those who have recovered, their risk is minimal. So obese patients who have got associated malignancy or a chronic liver disease, chronic lung disease, or a heart failure. So these are kind of patients who are asset prone to get a thrombotic complication. These are the ones where we are putting them on NOACs for at least 6 to 12 weeks and following up these patients. So those patients who are at risk of getting thrombotic events, they should have.
How do you assess that? How do you assess that?
From the history, if they are obese, requiring oxygen, non-ambulatory.
Will the D-dimer help?
Not really. I'm going more by the clinical parameters.
So,
Dr. Raja,
can I? Yes. So just to add, so I agree with what Dr. Chabra said completely. Just to add to it, I think if you're releasing someone with a D-dimer of above 2000, or if your D-dimer has gone up by more than 1000 during the course of admission, along with all the risk factors that Dr. Chabra described, the D-dimer would be a good endpoint in trying to give oral anticoagulants to these patients. And 4 weeks is generally what's been recommended in these individuals.
Dr. Claire, in your opinion, anything you want to say?
I would more or less agree with Dr. Raja, what he said. One has to define the probable risk, somebody obese, somebody diabetic, somebody having comorbidity, even if he has recovered from the COVID. I think to prevent these thromboembolic phenomena, perhaps 4 weeks is a good amount of time to cover them. These patients.
So
the thing is, just want to add is that patients who recovered from severe episode of COVID and they feel good, even if their echo is normal at the time of discharge, they should be advised not to do exercise or things of that nature for next 2-3 weeks, because some patients will develop malignant arrhythmia and they can die. Just a drop dead with every recovery, which has been documented already.
So one question has come. That's for you actually, Dr. Claire, that somebody says I am allergic to sulfur. Can I take hydroxychloroquine?
I personally, I don't know the exact answer of this, but I think it should not be a problem.
Yes. So anybody has any opinion on that?
It should not be a problem.
That's not a problem. So, so now the question is steroids. When you are discharging a patient with bilateral pneumonia, say 60%, 70%, Dr. Chabra, will you give them steroids if they have no deoxygenation, they are comfortable otherwise? At the time of discharge.
Most patients do not require a long course of steroid, but there are some patients, again, we have to carefully select. Now, patients who have a sustained elevation of CRP, those are symptomatic, require oxygen, then in these patients, it's advisable, in my opinion, to continue low-dose steroids for some time and follow these patients, whether the fibrosis is progressing or not.
How would you follow them up? How would you?
first CT we have done at 1 month. And most patients, fortunately, are not progressive. Then we do CRP at 1 month, and most patients CRP comes down to normal. So that is what we have seen in about 200 patients. But there will be very few patients who will actually require long-term steroids. So post-discharge, some days of steroids may be required, low-dose steroids, and then we have to follow and see that we taper them off. So assessment is important.
Raja is expert on steroids. Tell me.
So I think the recovery trial, the only data we have is the recovery trial, which is
No. Tell us about the post.
I'll tell you. So post-COVID, I think if you're going to give it beyond 10 days, the CT should be in severe COVID patients, especially patients who've gone on to invasive or non-invasive mechanical ventilation. You would try and wean steroids off over a period of sometime around between 6 weeks to 3 months, and no more than 3 months. You would repeat a CT at 2 to 3 weeks, or do the first CT at 2 to 3 weeks, repeat a CT again at 6 weeks, and maybe at 3 months before you're stopping the steroid. Just one thing, Dr. Khilani, just one thing about the previous question about the salt, the sulfur allergy. I think the question was alluding to the salt. So chloroquine sulfate or hydroxychloroquine sulfate is the salt of the drug. So if you're allergic to sulfur, maybe you need to be cautious about the salt rather than about the drug moiety itself.
HCQ is fine. So DJ, any choice of steroid? I mean, any thoughts on steroid? Please unmute yourself.
Yeah. So we normally give it for 10 days. And beyond, I mean, I have to say that beyond this, all of us that are delving into an area where there's no evidence. We do not know whether giving steroids will reduce fibrosis. We do not know if the airways will be better. But if patients, by the time you stop, are still hypoxic, still on oxygen, we have chosen to extend that till they are off oxygen. So that's a personal choice, not backed by any evidence.
So if I'm permitted to give my views, I look at the CT. If the CT has interstitial thickening or peripheral base lesion which are persisting at the end, other thing which I do is 6-minute walk test. If they have a normal saturation, if they are desaturating, I mean this is whimsical, you can say, but I look at the CT, I look at the desaturation on walking, and then give them steroid for a period of 3 weeks in tapering dosages, and then decide at what stage to do CT. It's easier said than. You can't be doing CT every 4 weeks. It's difficult and it may not give you relevant information. We also don't know whether steroid actually reduce the fibrosis. That is also a big question. And anti-fibrotic drugs we are not talking about. Yeah, Chhabra, last word from you.
The thing we can do is spirometry later on. That is a very good tool to follow.
Whether you do 6-minute walk test or spirometry, people say that 6-minute walk test is little better than the spirometry, but that can be debated among the pulmonologists. So, ladies and gentlemen, we have had an amazing presentation, and if I could summarize it, majority have felt that hydroxychloroquine, ivermectin, azithromycin, doxycycline, we haven't found any evidence of benefit. The role of steroids is definite, but one should be very careful not to give in the mild disease. Now we have crystallized the indication. There's probably nothing to choose between dexamethasone, hydrocortisone, and methylprednisolone. No ambiguity about anticoagulation. All hospitalized patients should receive anticoagulation once a day or twice a day, whether prophylactic or therapeutic dosages. That, of course, has to be decided on case-to-case basis. Convalescent plasma therapy, earlier the better. Safety is documented. Efficacy, we are still struggling. What the remdesivir is a drug which seems to be a game changer as far as the therapy is concerned. Should be given in patients with bilateral pneumonia, even the patients who are not desaturating. And about, of course, Dr. Claire instilled a lot of wisdom as far as the cardiac aspect is concerned. Don't worry about bradycardia, just monitor them, do troponin and CPKMB liberally, and of course the how to continue anticoagulation, steroids, that is of course very important. And I'm really grateful to a grand organization like FICCI, who gave us opportunity to present our views on this. I hope they have been useful. And my personal gratitude to Dr. Harsh Mahajan, who is the organizing chairman of the scientific, Dr. Aarti, who is moderator, and then so many people who have been helping day and night, especially Miss Marwa, who has been in touch with us. I am big thank you support for office bearers of FICCI who have been organizing. And finally, you would all agree with me that my gratitude to all the faculty for their outstanding contribution. And I'm sure at least I have learned a great deal from each one of their experiences. And let me promise you that these four people, and of course Dr. Ankur, I find they are the most experienced people in COVID in this country. From Kolkata, from Vellore, from Delhi, and then of course trauma center. Anjan has been managing thousands of patients. So they have all added their wisdom to this discussion, and I hope it will have been useful for the participant. And thank you very much. I wish you a great lunch. Enjoy the lunch and catch up some rest. Thank you.
So on behalf of FICCI, I take this opportunity, sir, to convey our sincere appreciation for your contribution towards the success of this honestly very informative and insightful session. Brilliantly designed, Dr. Khilnani. It was definitely a privilege to have you over to share your views and learnings with our delegates.
My honor.
And with this, we come to the closure of this session. Thank you so much, everyone, for joining us.
I would like to say thanks to Professor Khilnani, and it has been wonderful to hear to Dr. Christopher and Dr. Raja, very clear understanding. And to be honest with you, I really learned a lot from this webinar symposium. Thanks to FICCI as well as my main thanks to Professor Khilnani, who involved me in this program. Thanks a lot.
Yes,
Thank you, sir.
Thank you. Thank you very much.
Thank you.
Thank you. Thank you very much.
चलो उनको पेशेंट लगाओ
Afternoon to all delegates and speakers. On behalf of FICCI, I would like to thank each one of you for sparing time and joining us for this very important conference in such large numbers. Before we begin, I'd like to thank Dr. N. Subramanian for chairing and moderating this session on non-COVID treatment, the changing protocols. He is the Director, Medical Services at the Apollo Hospitals, New Delhi, where he has been a senior consultant, urologist, and uro-oncologist since the year 1995. A medical graduate and postgraduate from University of Delhi, a fellow of the Royal Colleges of Surgeons of Edinburgh and Glasgow and the International Academy of Sciences. Last but not the least, he's a strong advocate of medical audits and culture of safety. Over to you, Dr. Subramanian.
Thank you, Malik. I think let me welcome each one of you. I think we have an amazing selection of panelists today. But before we go into specifics, let's look at the subject for today. We have all been seeing the impact of the COVID, the magnitude which has been global. It's been a pandemic involving almost every country, which has incarcerated almost a third of the entire global population. Over 30 million who have suffered from the disease, over 1 million who have died. There are several more with active disease, and it's not only something which has affected the health of individuals, it's not only affected lives, it has impacted livelihoods, it's affected transportation, it's affected travel, it's taken a significant toll on the industry and business. So it's a very, very major global situation. When we look at countries who have been very much on the top in terms of the global health security index, when you look at a lot of Western Europe, the United Kingdom and the United States, these have been right on top in the security index. And yet they've had to really, really struggle in the face of this sudden increase in the need to hospitalize people. It's not only the magnitude of the disease that's been a concern. This is one of those diseases where it is not only about treatment or diagnosis. Preventing transmission became one of the most important parameters, be it in terms of preventing the staff and the healthcare worker from contracting the disease or spreading the disease. So it's a big concern has been, how do you deliver healthcare? How do you deliver care for non-COVID medical conditions without causing a further spread of the disease? Many of the countries resorted to some degrees of variable lockdowns, which perhaps helped the countries to probably gather their acts together, as one would say, and to be a little better prepared, and might have postponed or delayed an explosion. However, there has been a considerable increase and increasing numbers of those afflicted by this dreaded condition, and therefore the struggle continues. When you look at countries like Western Europe, the United States, or rest of the North America, you know that there is a lot of state-driven healthcare mechanisms, right from the primary to the tertiary care. There is a kind of an established system. In India, we have a mixed system where health comes under a state-governed mechanism, and therefore each state has its own priorities, may have different laws, may have different systems, which has also impacted the whole mechanism. Further adding to the problem, as you know, is the number of doctors available for a given population. Similarly, the availability of the number of beds per given population. We know that countries like Italy, especially segments like the Lombardy, had a very good patient to doctor and patient to beds ratio. And even these countries struggled. We also know that those of the countries like India, which got into it a little later, perhaps about 8 to 10 weeks after some of the Western European countries and the United States became afflicted, probably had that little cushion to learn from the initial experiences of these countries. But we know it is not only the healthcare that has been affected. In a country like India, which actually has a population beyond all the other countries I just mentioned, we also have had a challenge that historically we've not had a great investment in health infrastructure. Secondly, we have the double whammy, where we have both a significant proportion of non-communicable diseases and infective conditions as well. And where over 70% of the nation depends on private healthcare, and 65% of the healthcare expenditure comes from out of pockets of patients and their families. So with that background, we realize that it's not just about diagnosis and treatments. Even hospitals like mine, we are a 72-strong hospital group. We are a tertiary care hospital. My own hospital in a normal year would do about 500 renal transplants and about 150 liver transplants. We have robust systems, and yet we needed sudden changes to airflows, sudden changes to air conditioning, sudden creation of negative pressure chambers. We had to create complete segregation of what Rajesh described earlier as the COVID red and COVID blue zones. But at the same time, we also know in India, the impact of the cardiac diseases is so high. You and I know that the world loses close to about 7,000 people a day to cardiovascular diseases. Over 2,000 people die every day due to conditions related to cancer. So delaying or avoiding chemotherapy or radiotherapy or dialysis was not an option. So it is a mix of how things had to be done. Then we had to go forward looking at what happened to the training of the various trainees. What is the value of people being generalists versus specialists? How do you make sure the motivation in the staff remains? How do you ensure that the patient's confidence is restored in the flow of the system? So there are several dimensions which you and I would need to address today. And it's brilliant to have such an eminent faculty representing Italy, representing the UK, and of course the College of Surgeons at Edinburgh. We have Dr. Raman from Mumbai, who represents a wonderful system. And of course, we have Dr. Arun Prasad, again, one of my colleagues and a very eminent surgeon. So I thought it may be a good idea for us to start tracing how the disease pattern went about. So I thought it may be a good idea to begin with Professor Mario Mosella. Let me briefly introduce Mario. Professor Mosella received his medical degree from the Federico II University Medical School, Naples, Italy, and completed a general surgery residency at the same institution. He also completed 2 fellowships to improve his surgical expertise at the Complutense University of Madrid in Spain, and at the General Digestive and Abdominal Organ Transplantation Unit, again in Spain. Professor Mosella is currently Professor of Surgery at Federico II University and in Advanced Biomedical Sciences departments of Naples Medical School. He has served as a university researcher and a staff surgeon in the Department of Experimental and Clinical Medicine, General Surgery, etc. He is also focused on endocrine and bariatric surgery. Professor Mosella is a member of several Italian and international societies in general, bariatric, and endocrine surgery. So I have great pleasure in introducing Professor Mario Mosella. Mario, over to you.
Thank you. Thank you so much, Dr. Subramanian. Thank you for your flattering introduction. And let me thank also the FICCI for this invitation and my old friend, old bariatric friend, Dr. Prasad, and for involving me in this. Well, I prepared very few slides to present our experience here in Italy with regards to the protocols and how the situation has changed in these last months here in Italy. In this first slide, you can see the variation we had in these last months in Italy, starting from March 1 and up to today, up to the end of September. This is the variation. The red line is the variation of total infected people. The blue line is the currently infected people who are currently infected. The yellow line is the variation regarding the healed people, the discharged or healed people, and the black line is about the casualties we had in these months. As you can see, there's been a peak around the end of March, the beginning of April. And this is the situation currently with regards to this last month. Starting from July 22. I'm sorry, but I got these slides from the Italian Institute of Health, so they're in Italian, but it's always the same. The red line is the variation of total infected people in these last months, and the blue line is the currently infected people. The yellow line is the variation of discharged or ill people, and the black line that is very flat. So thanks God, regarding the casualties, the deaths we had in this last month here in Italy. Well, this is a general overview. It is interesting to see the differences. Now we are experiencing a new rise of the number of infected people, the number of cases. But at the beginning, you can see this was the beginning of March, we had a lot of cases, especially located in northern Italy. As we were discussing before with Dr. Subramanian, probably this was due to a very close relationship, a business relationship regarding the fashion area that some areas here in northern Italy have with China. There was probably a lot of traveling people between Italy and China, and this probably favored the spread of the infection. But at the beginning, it was suddenly and only there. In the middle of January, we heard about this outbreak in China, but we did not worry too much. But it was in a couple of weeks that we realized that the situation was getting serious and serious here in northern Italy, because we started with a lot of infections and a lot of deaths. And this was impressive, especially because Italy has been the first country in Europe interested with this outbreak. And once again, basically, probably the only reason is this business relationship with China. In the south, the situation conversely, where I live in Naples, was more relaxed, was more clean, more calm. We had a few cases. Conversely, now the situation is more equally present in all the country. We have a similar number of cases in northern Italy, in Rome area, in Naples, or in Sicily. So the infections are better distributed in the country. The slides basically shows you the case notified in the last 30 days in Italy. The green bar are the asymptomatic people. This is related to the month of September. The blue line is the pouchy symptomatic people. The yellow are the mild symptomatic people, and as you see, only orange and red, the severe and critical people is a very small number of people among all the infected people. This is interesting. And going ahead, well, what we've been forced to do, what we've been asked to do with regards to the different of types of surgery we do here in my hospital, in all the country, of course. Well, the all elective surgeries have been stopped, starting from March 9 and up to the end of April. I would say up to the May 4 or 5, we've been stopped to perform any elective non-oncological or non-urgent surgery. Only oncological or emergency surgery were allowed in this 2 months period. And of course, if an emergency surgery was requested, the people were screened at the time. Now there's a great number of swabs available, but at the beginning of March there were very few swabs available. So we had a serological rapid test that, if was negative, allowed the surgical equipe to operate in standard condition. While if the serological test, rapid test, was positive, of course, the surgical equipe had to protect itself with masks, with double gloves, and surgical gown or surgical glasses, and special types of masks, of course. The same masks were not easily available at the beginning of March. Now, the situation is totally different, of course. This is a quick picture of the way we had to perform surgery in emergency if the patient was positive. So, this is remembering that Italy has been, once again, the first country in Europe. At the beginning, there was a sort of skepticism coming even from other European countries that were quite surprised about the gravity and the speed with what the infection was coming out in our country. But in a very few weeks, I would say, France, Spain, and then UK also started to experience this nightmare. Only Germany probably has been a little preserved from this, but they started by immediately to do a large number of swabs according to the 3Ts theory. I mean, so to test, to track, and to treat patients as soon as possible. This is a paper that we released as the Italian Society for Bariatric Surgery. That this is a flow chart presenting the way we started once again to do bariatric surgery. As I told you a couple of slides before, we've been stopped in March and in April to do bariatric surgery, and we've been allowed, but starting from May 4, May 5. But this was in a lot of cases depending from the different regions. We have 20 regions in Italy, and for example, we in Campania, we were allowed to do bariatric surgery, while in Lombardy or in Veneto, they were not allowed to do any elective surgery. Well, this is a very quick overview of the very recent treatment protocols, and just a quick highlight about, I think, has been an important moment in the development of discovering and studying this illness. In Lombardy, there's been a lot of deaths. The situation has been very critical in March and April, and in an hospital in Brescia, following the first 50, I would say, or 60 casualties, they started to make autopsies in these cadavers, and so they discovered, I think that it was very important, that this thrombotic presentation in the lung circle, and they started to treat this patient with antithrombotic drugs as well. This has reduced in important manner the number of casualties in this case, and of course the use of steroids that remains, especially if you use it early, an important passage. So what do we now? What do we do now? What we've been asked to do now? Well, all the health workers are requested to undergo very routinely and weekly serological or molecular test by swabs. The elective surgery patients are requested to have a negative swab the week before they are operated, and all the emergency surgery, of course, are still treated or screened with a rapid serological test. So this slide is just remember is an homage to the great number of doctors and nurses. They lost their life in the attempt to save all their patients in these horrible 2 months we had in March and April this year. Thank you so much for your attention.
Thank you, Mario. I think that was an excellent overview, and not only in terms of looking at what happened in Italy, but also gives us an overview as how you dealt with things in the beginning, how you had some increase in the cases, and how you are dealing with the non-COVID work in the most effective fashion. That's brilliant. I think now we'll go on to learn something from the experiences from the UK. I'm delighted to welcome Mr. Pala Rajesh, who's the Senior Vice President of the Royal College of Surgeons of Edinburgh. After qualifying from Madras Medical College in 1974, he got trained in the UK in general surgery and obtained the FRCS Edinburgh in 1982. His training in cardiothoracic surgery was mainly in Yorkshire at Hull and Northern General Hospital in the University of Sheffield. After completing his training, he obtained the FRCS Ed Cardiothoracic in 1994. In May 1995, Pala was appointed as consultant thoracic surgeon at Birmingham. He has been involved in teaching and training in cardiothoracic surgery since 1995. He has been the regional advisor and the regional training director for West Midlands Deanery. He has also served as a specialist advisory committee in cardiothoracic surgery and in the court of examiners of both the Intercollegiate Specialist Board and the Joint Surgical Examinations. So it'd be lovely to hear what Rajesh has to say about his experience. Over to you, Rajesh.
Thank you very much, Subramaniam, for your kind words and for the introduction. This pandemic has probably been the single most important learning experience in any medical professional's lives. We've never come across any such unusual presentation in our working lives. As Professor Masala said, we did wait and watch in the United Kingdom as to what was going on in Italy. The first obvious death was somewhere in the last week of February in the United Kingdom, in Brighton, and subsequent to that, the government decided to go on lockdown in the third week of March. We in the United Kingdom have a national health service which is state sponsored. The private sector is a small provider, probably up to 8 to 10% of the nation's needs. Now, how did the National Health Service respond? The immediate process of converting hospitals into COVID red zones and non-COVID blue zones took place. the accident and emergency department was converted into a COVID zone. And we had a separate entrance in some of the university hospitals where patients came for their non-COVID treatment through a blue zone. We had to deploy medical, nursing, and paramedical staff to the front line. This was an uncomfortable issue for a variety of frontline professionals who had not participated in infectious disease control. We stopped all non-emergency work. All of the cold operating and cold cases were completely stopped. And COVID-19 and emergencies only were carried out. We had to have a rapid training of the redeployed staff, which took a week to 2 weeks. The trainee workforce in the National Health Service had to be deployed into the front line. The consultant workforce were also deployed, and we found that there was a procurement crisis in the country. We found that we were not prepared for the amount of PPE that was necessary. So we had to scramble to find ways and means of procuring the PPE equipment. And we found that some of the equipment which was flown from overseas were not up to the British standards. The next task which the CMOs and this Department of Health and the Secretary of State for Health requested was to have guidelines. So the joint surgical colleges, along with the 10 surgical specialty associations in the United Kingdom, put out a immediate guideline followed by surgical guidelines. We said that use of personal protective equipment is mandatory in the ward areas, admission areas, operating theaters, and intensive care units. Non-essential surgery should stop immediately. We had surgical guidelines where we prioritized according to the need. Level 1A was for emergencies where the operative procedure should be carried out within 24 hours because it's a life and death situation or loss of limb. Level 1B was urgent, where the operative procedure needed to be carried out within 72 hours. Level 2 was when surgery could be deferred up to 4 weeks. Level 3, surgery could be delayed for a period of 3 months. And level 4, where surgery could be delayed greater than 3 months, which were normally the cold cases which were on waiting lists. Now, with the emergency surgery, just like what the Italian experience was, we made sure that a blood sample was taken for COVID, but we proceeded with the operative procedure and looked at the results post-operatively to see whether the patient was COVID positive or COVID negative, and sent him or her to the appropriate area for post-operative care. Now, if the patient had an acute abdomen, then a CT chest was also done at that time in March to make sure that there were no respiratory involvement. And if the patient came in for a operative procedure which was deemed to be something which could wait, then we requested the patient to self-isolate for 14 days. The patient who underwent a COVID test, if it was negative, and then the patient was informed in his consent procedure that there was a probability that COVID-19 after surgery was high and adverse events may happen. Aerosol generating procedures were stopped because it was felt that it was high risk. They needed full PPE, and just as the Italian experience showed, they need disposable gloves, double gloved, fluid repellent gowns, eye face protection, FFP2, 3, or N95 masks, and the practice of sterile donning and doffing of PPE in advance was done. Laparoscopies were deferred because we felt that the deflation after procedure with filters and traps were important, because it was felt that we must have safety first approach to protect staff and patients. And the next interesting area that we learned from was the presentation of these patients, whether they were asymptomatic, whether they were mild to moderate or severe according to the tests and the presentation. And the protocols for care for mild and moderate was self-isolation, analgesia, and it was felt that in 7 days the viral load should reduce. If it was greater than 7 days, then they should seek the care of their own general practitioners and NHS life helplines, and not turn up to A&E unless they became severe. Now, with the severe patients who turned up at our doorstep, it was unrelenting fever. The care was mainly supportive. We were looking at all of the literature which was coming out. These were literature which was coming in waves, streams from all over the world with each other's experience. And it was mainly supported in the UK. People who were hypoxic, people who needed intensive care were immediately intubated and underwent intermittent positive pressure ventilation. But we soon learned that most of these patients didn't do well. Especially in my specialty, we found that we were putting a lot of these patients on extracorporeal membrane oxygenation with the 45% mortality. So that lessons which we learned were because of the pathophysiology of the condition, where endothelial dysfunction seemed to be the most important area that we all understood. And we started treating these patients with blood thinners, with anticoagulants, with antithrombotics, and the Oxford group with the recovery trial came up with the suggestion that dexamethasone would prevent cytokine storms. Now, the lessons learned were in the respiratory, cardiac, neurological, gastrointestinal, musculoskeletal, and hepatobiliary areas. Now, thus far, in those 2 months, we had no approved treatment. Hydroxychloroquine was tried. It was found to be toxic. The antivirals of remdesivir and the introduction of antibiotics was azithromycin. The double trials were all performed and they were all deemed unsatisfactory. The only real light at the end of the tunnel was from the recovery trial from Oxford, where we found that using dexamethasone, a cheap medication in the UK, was probably the best solution to prevent not deaths, but to prevent cytokine storms and to reduce the burden of the intensive care units. We've tried immune-based therapy, plasma replacement, and none of these have really been a panacea for the treatments. So, what are we doing at the present time? At the present time, we have got our hospitals up and running. We are looking at a second surge like they have had in Europe. We are preparing for the winter. What we don't want is for any overwhelming use of the NHS. We have had Nightingale hospitals set up in record times in 4 important cities, in London, in Birmingham, Manchester, and in Glasgow. We may be in a position to use those areas for the future. Now, what impact has it had on medical training and in further delivery of healthcare in the UK? Now, out of every adversity, there's always an opportunity too. As far as the trainees are concerned, the General Medical Council, which is the regulator in the UK, have informed the specialist advisory committees and the colleges via the Academy of Medical Royal Colleges that whatever experience they have had over these past few months is invaluable. They have learned something. It may not be a subspecialist area of surgery or a subspecialist area of medicine. However, they have learned communication skills, they have learned interpersonal relationships, they have learned how to be resilient in extreme areas of stress. Mental health has become a very important issue with both the medical um, profession and their relatives. In the UK, some of these young doctors are married to doctors, they have young children, and to be fair, it is so important that they are protected. We've also had a unusual situation where the Black, Asian, and doctors of minority ethnic groups have had a higher mortality, and that's now being looked at as a research trial. And the trainees are waiting in anticipation of taking their examinations because we have a, program of 6-year training in surgery post membership where some of the senior trainees of ST year 6 and 7 are waiting to take their exit examinations. So how are we going to hold these examinations? Are we going to convert them into online examinations? And if they convert them into online examinations, will the experience be the same of taking these examinations online, whether it has to be face to face or a hybrid, a blend? So that's one of the issues which is ongoing at the present time. The second major issue is delivery of healthcare. We have found that using the internet platforms like web platforms like Zoom, um, Microsoft, etc., have been so useful that the Royal College of Surgeons of Edinburgh have held webinars ever since we went into this lockdown. And we have learned that a huge number of interested people have participated in these webinars. And we've exchanged a lot of information on how various countries are treating, going through this pandemic, and also how they are educating their trainees and young surgeons at the present time. So, a group are now looking at delivering healthcare on a hybrid platform, whether the outpatients can be seen through a web platform, whether patients who really need to be seen can be seen face to face with appropriate physical distancing, whether the multidisciplinary team meetings for cancer, for cardiac diseases, respiratory diseases can be held through a web platform. Um, and the post-operative care can also be distributed through a variety of paramedical workers. So I think we have had a learning experience. We will continue to learn. And it's my own view that it will be a blended way of delivering healthcare, which will probably be so useful for a country like India. So with that, I would like to thank Subramaniam, the FICCI, for giving me this opportunity to present our experience with tackling COVID, both in the non-COVID situation and in the COVID situation. Thank you very much.
Thank you so much. I think that was such a comprehensive overview of the disease problem itself and the healthcare delivery and training and going beyond. I think that is tremendous. Now, let me invite my colleague. I will invite Dr. Arun Prasad. Arun has kindly stepped in, as we know that Professor Kasama had a family tragedy because of which he couldn't join us. Arun was kind enough to join at a very short notice. Dr. Arun Prasad is a bariatric and robotic surgeon at the Indraprastha Apollo Hospitals. 36 years of total surgical experience, a senior consultant for the last 25 years, since 1994. His training began in India and then subsequently for 6 years in the United Kingdom. He has been involved with the laparoscopic surgery from the time it started in the UK in 1990 and belongs to the first generation of laparoscopic surgeons. One of the first in the UK to do laparoscopic cholecystectomy and hernia repair on a day care. One of the first surgeons to do minimally invasive hemorrhoid surgery, endoscopic thoracic symphylectomies, single incision laparoscopic surgery of gallbladder, appendix, bariatric and thoracoscopic surgeries, experience of over 10,000 laparoscopic surgeries that include over 6,000 laparoscopic cholecystectomy, laparoscopic hernia surgery, and advanced laparoscopic surgery, including thoracoscopic, pediatric surgery, and over 500 robotic surgical cases. Arun, apart from being a good surgeon, has also been very active in publishing and presenting. He represents the Institute very well and participates very actively and is a thinking surgeon. Arun, would you like to come in and share your thoughts?
Thank you, Dr. Subramaniam, for those kind words. And it's been great to hear the European and UK experience, which our friends have just gone through. What I would do is partly take people through as to our experience in India in general, but in particular with my institution. So when the lockdown started in the second half of March earlier this year, our hospital team, led by none other than Dr. Subramaniam, who's here with me in this program, took over the challenge of converting our tertiary care hospital, which is a private institution, to cope with the COVID situation. So this pandemic response plan included immediate postponement of elective operations, OT plans, and admission strategies. So Dr. Subramaniam and the other administrators, with our intermittent suggestions, took over this challenge day and night and got through with a lot of infrastructural changes in the hospital. This included things like creating a COVID corridor, sealed areas for COVID patients. Emergency was also segregated into fever and non-fever, that's COVID and non-COVID patients. And we also went ahead and constructed an entire area of COVID operation theater or operation rooms to deal specifically with COVID-related surgical complications. This required a lot of effort because all the staff had to be trained into basics of PPE, which none of us knew about it. Initially, when we saw this, it all appeared to us as if we are going to go on the moon. But gradually, we all got educated by mostly reading and by learning from the experience from other countries. This also ensured that no emergency service suffered. That was very important. Educating the staff on personal protective, that's the PPE, and basics of COVID-19 management was also a part of the initial agenda of the hospital. Developing anesthesia and surgical protocols for safe surgery, that was also a very crucial part. because the anesthesia is an aerosol generating procedure. So the anesthetists and their societies got together to form guidelines. Similarly, the surgical protocols for safe surgery was made. And I'm so glad and proud to be here on the platform with my dear friend, Dr. Raman Goel, who spent day and night getting an Indian protocol ready. We have multiple surgical societies in India. So to avoid, confusion and overlapping, we got together, and with the leadership of Dr. Raman Goel, we made what is known as a joint guideline statement for minimal access surgery, where all the societies got together. Initially, there was some question about minimal access surgery not being safe, but eventually we realized that actually it was safer than open surgery. Now that's a topic of debate and a separate discussion altogether. Developing special steps and acquiring technology to reduce aerosol and smoke generation during surgery was very crucial. So we evaluated quite a few machines, and our hospital on an urgent basis acquired these smoke filters and viral filters, which helped a lot in building the confidence of the surgeon and the healthcare workers to undertake surgery. In this situation, because there was so much panic and scare, the hospital took a lot of steps just to reassure the staff that they are going to be safe, and if something happens to them and their family, the hospital is there for complete backup and care. So with this kind of support, we made a COVID team which were looking after the COVID patients. We also had all our surgical and other departments supporting things. Before surgery, all patients were screened in the OPD for COVID-19 symptoms. RT-PCR was done. In selected cases, chest CT was done. Patients who had to be admitted immediately, for example, appendectomy or bleeding or an obstructed hernia, were admitted in what we call as a gray zone area, where pending COVID-19 results. So this was a gray zone area where the patients were admitted till the time we got their reports. There they were, treated as COVID positive till proved otherwise. And once they were tested negative, they were moved to the regular wing of the hospital. Air conditioning in the OT. Now there was a lot of talk about negative pressure air OTs, which was not possible. So our societies got together and came to the conclusion that if we were to switch off the AC half an hour before the process of intubation, and also after extubation, again switch it off for half an hour, no staff goes inside during the anesthesia process, minimum staff is required inside, and these kind of guidelines were followed. I am a robotic surgeon and I was very happy with robotic surgery. Now people were asking me, why are you doing robotic surgery? And to answer that question, I'll take a minute. In robotic surgery, the surgeon is away from the patient and the anesthetist sitting on the console. There is one less assistant in the operation room. The tissue contact between the staff, the nurses, technicians, anesthetists is very minimal, because when the robotic surgery is going on, everybody is away. Then we have these special viral and smoke filters which we had. So I was actually quite happy with robotic surgery, and I have been talking about it everywhere as to how robotic surgery turns out to be so much safer. Anyway, that was a slight diversion. So to moving on, finally, what are the problems that we faced? One problem was that of an emergency room block neck. Because patients were delaying coming for surgery, so everybody used to land up with a complication. So all the patients who did not have their hernia surgery or gallbladder surgery were landing up at our emergency with empyema of the gallbladder, perforation, pancreatitis, obstructed hernia, and that was an additional load. So the hospital realized that well in time, and an extra wing for emergency patients was created. This is a problem that is still going on, though it's going to reduce. Our hospital was one of the earliest to latch on to the telemedicine, and we got an excellent app which was available both on Android and iPhone, through which our patients could do teleconsultation, and that reduced tremendously their visits to the hospital and reduce the crowd in the hospital. This is something which is still going on, and it has been one of the most successful programs of Apollo hospitals. We are looking at asking patients to get monitoring devices and software so that they don't have to come that frequently to the hospital. In future, what I think is that we need to be prepared for our second wave, and few things which may be difficult, but they have to be looked at, are things like location pooling, where we can combine the critical non-COVID services hospitals. Then we are looking at, cohort wards. So you can have a cohort ward of COVIDs. For example, if there are a lot of patients, so you have a COVID ward cardiology, just like, we have the various ICUs. So that is another future which is there. Then separate disease patients in the immediate acute phase. So if we have hospitals which have got multiple branches in the same city, the hospitals can actually divide and share between them and come to a rational way of how to handle this situation. So these are some of the things which are we are looking at, and we are currently dealing with our situation quite well, and also are prepared for the future. This is a picture which was there from yesterday's Times of India, which says COVID deaths top 1 million, but 15 diseases in India kill more every year compared to COVID. So non-COVID diseases, whose baby it is, this is something that has to be addressed. There are often, these news items which we see. Even our health minister of India has said that non-COVID patients must not be neglected. We have seen examples where delayed surgery on cancer patients. I had a patient who was given neoadjuvant therapy in another hospital. He came 4 months later because he was too scared to go out. And now he has
sorry, we've lost you, Arun. Arun, can you hear me? Will the technical team step in?
I believe there is some connectivity issue at his end.
Right. I think we'll give it a moment till he comes back so that, we can get a completion of what his thoughts were. Malika, should we then request Dr. Raman to come in?
Sure. I've been trying to call him. He's not answering. So you could go ahead with Dr. Raman.
Yeah, I think, Dr. Raman, is that okay?
Yeah, I'm good.
Okay, great. Now I have great pleasure in introducing Dr. Raman Goyal, a bariatric weight loss surgeon at the Hinduja Healthcare in Mumbai, the president of the Society of Indian Laparoscopic Surgeons. Dr. Raman Goyal, an MS, FIAGES, FALS, FRCS, Edinburgh, started therapeutic laparoscopy in 1990. He also received training in endoscopic procedures at the GB Pant Hospital, Delhi, and was trained by Professor B.N. Srikhande after his post-graduation at the JN Medical College in Aligarh. Dr. Goyal was the second surgeon in the country to start bariatric surgery in 2000 and played an important role in establishing bariatrics as a specialty in India. He performed India's first gastric banded gastric bypass and mini-lap bariatric surgery. He was accredited as the first Indian surgeon of excellence in bariatric and metabolic surgery. a laparoscopic surgeon with over 30 years of experience. Dr. Goyal was Associate Professor of Surgery at the Grant Medical College, Mumbai for 16 years from 1994. For the last 20 years, he's practicing bariatric surgery. Currently, the President of the Indian Association of Gastrointestinal Endosurgeons and the Scientific Committee Chairman of the World Congress of Endoscopic Surgery, scheduled for 2024 at Kolkata. He is also the Board of Governor of both the International Federation of Societies for Endoscopy Surgeons, that is IFSES and ELSA. So let's welcome Dr. Raman Goyal.
Thank you. Dr. Subramanian. It's a pleasure to be on the FICCI platform, and I must thank Dr. Arun Prasad for inviting me to join this elite panel. I think the topic, the non-COVID treatment and changing protocol, is so relevant, especially in Indian context, because India, compared to Western countries like UK and Europe, is so different in its healthcare system. And why did we require these changing protocols? Because nobody, not the doctors, not the governments, had any knowledge or experience of managing a pandemic when it suddenly hit us somewhere in February and March. There was no pre-existing SOPs for managing non-pandemic diseases in a pandemic. So we gradually started learning as we were managing our patients. Sometime in third week of March, we all know the country went into a lockdown quite early, and which gave it time to recoup, to build up capacities, and all activities came on a standstill. There was practically no public movement or interaction, and that had major impact on non-COVID issues, because the entire focus of the government, the media, and the public was on COVID. So somewhere in early March, I remember seeing these bus hoardings that if you have cough, if you have fever, and if you are breathless, please go and see your doctor immediately. This was the guideline that was actively promoted in March, thinking that if somebody is falling sick, one should seek a doctor. And then we were told to stop all our elective work and only emergency care was permitted. And this was compounded with the fact that there was limited testing access because the country had limited testing kits available. And with this, in late March, suddenly we had hundreds of unsuspecting healthcare workers who got infected with COVID, from asymptomatic COVID positive patients who came for other emergency care. In my own hospital, almost 85 of the staff members got infected through one cardiac patient who came for angioplasty and had to go through ICU and the routine room, and 85 of them got infected. And like that, another hospital, a renal patient with asymptomatic COVID positive renal patient infected the entire hospital. On the other side, the family physicians where the patients were told to approach in case they had a respiratory symptoms, they were also the first one to have to fall for COVID, and they became positive. So what happened somewhere in April, second week of April, the hospitals were shut by the authorities because they became the super spreaders. And the doctors, many of the family physicians, closed down their clinics themselves, realizing the dangers involved in COVID. So this necessitated policy changes, guidelines changes, and it impacted care of patients. Now, compared to January, in April, there were 50% less OPD attendance all over the country, 60% reduction in inpatient care, and 50% less surgeries. Now, imagine its impact on non-COVID patients, because all our hospitals normally run full with non-COVID patients, and the drastic reduction in patient care had its adverse impact on non-COVID diseases. Like somebody like me who is doing exclusive bariatric surgery for 10 years, completely stopped bariatric surgery for 4 months because it's an elective surgery, and no patient or the surgeon would like to take a risk in that situation. Then there was an impact on communicable diseases and non-communicable diseases. Now, from India alone, a UNICEF report recently presented during the General Assembly says that 500,000 patients of tuberculosis was missed during the first 6 months compared to 2019. Just in the last 6 months, 500,000 tuberculosis patients were not diagnosed or not notified. 1 million children did not get their BCG vaccination in April alone compared to January. And these are the kind of diseases which are going to impact healthcare of the citizen in long run. Then the mother and child care. So compared to January of this year, 6 lakh less deliveries happened in hospitals. So probably they had a potentially unsafe deliveries at home. And up to 6 lakh additional children are likely to die in next 6 months due to limited food availability. This is a recent report presented by UNICEF. So we are looking at not the major impact of deaths or on death through pandemic. We are looking at a major impact for multiple other factors. And this is a report of NGO Save the Children, about the children care. Then oncology, which was highlighted worldwide, had major impact in India also. Though Tata Memorial Hospital, Mumbai continued to see patients, but the movement of patients were not able to reach out to hospitals because the communications were completely broken, or those who came to Mumbai for treatment or other cancer centers could not go back home because there was no way to go back. So it is estimated that almost 60% of cancer surgeries were postponed in first 12 weeks of disruption or lockdown. And that led to postponement of about 50,000 cancer surgeries. Now we know that every time a cancer surgery gets postponed, it leads to upstaging of the tumor, and which may lead to a situation where a person can miss an opportunity to have a curative removal of cancer, and then it becomes person has a worse outcome. So these are the issues which we must consider. I think they were, as far as my own specialty surgery is concerned, there were surgical concerns, the risk of COVID to patient and the family and friends from hospital. Then we had early reports from Wuhan, China, which says that there can be COVID in surgical smoke, and which can potentially infect healthcare workers. Now, healthcare worker is a resource, it's a national resource during pandemic, because if they fall sick, there is reduced manpower, there's a risk of life to them, and there is a risk of infecting future patients. So all these issues were weighing heavily on us, on people who are leading the associations. And then there was a risk of COVID in operated patient. There was another study from Hong Kong which said that if COVID happens in operated patient, the mortality may be as high as 20%. So higher morbidity and mortality and medico-legal implications were the issues. And then, as Dr. Arun Prasad mentioned, under the leadership of IAGS, we collected all other associations, and we came with inter-association surgical practice recommendations in COVID-19 era, which were subsequently published. And surgeons across the country were very happy to receive them and followed them. Primarily, these guidelines were, please don't do elective work, only stick to emergency work. All those are almost similar to what was practiced in UK and Italy and worldwide. But then the realization started settling in, because the initial guidelines were based on the assumption that all these emergent measures like social distancing, lockdown, hygiene will break COVID cycle. And after a peak, within 3 to 4 months, the life will come back to normal. But this did not happen. And when the disease spread to different geographical locations within the country, the testing capacity improved, and we realized that this COVID is going to remain active maybe for a year or maybe more than a year. And thus, we need to modify our approach. So the new guidelines came where governments asked doctors to open their clinics, teleconsultations were encouraged, healthcare facilities were told to manage non-COVID patients, and COVID testing, which was initially not even accessible through a doctor's prescription, is now available without any prescription across the country. Euphoria, which was there at the time of lockdown, was replaced by fear and then by realism that PPE, the coveralls are not required for non-COVID patients. A good quality mask, hand hygiene, and social distancing is enough. Seniors and male patients are at high risk, so they should be shielded. And herd immunity is not going to happen. We must have read in the newspaper today morning a recent report by ICMR that only 6.6% of the population countrywide is probably infected with COVID even after 6 months. So somewhere about 2 months back, the IAGS, our association, came with new guidelines calling it resumption and restructuring of surgical practice recommendations in COVID-19 era, telling surgeons that based on the recent research, the surgical smoke is probably not that dangerous. One can use a filter and can go and operate, do a laparoscopic surgery. Essential and semi-urgent surgeries should be considered for taking it up. And gradually, surgeons started doing elective surgeries because the hospital got earmarked. This is a COVID hospital, these are non-COVID hospitals, and patients and surgeons got confidence to operate them in those hospitals. Concurrent healthcare is required. COVID is one part and non-COVID have to be done. Dr. Pala Rajesh has already mentioned about the zones. Most of the hospitals follow those zones. And the priority at the moment is to restore public confidence in safety of healthcare establishment because there is an element of fear. Rapid identification and treatment of delayed or deferred care patients, those who have been delayed for 6 months. Then doorstep provision of safe healthcare is the necessity. Probably we need to restore public healthcare on an emergency basis, and acceptance of fact that virus is going to stay till an effective vaccine comes. So to conclude, Mr. Chairman, I quote from Dr. Madhukar Pai, who is the chairman of research of epidemiology at McGill University, Montreal. He says, if there is one lesson this pandemic has taught us, it is that investing in health is not a luxury. It is an essential basic human right, and the world's economy depends on health. So thank you so much for involving me in this panel.
Thank you, Dr. Goyal, for a very, very comprehensive and a very effective presentation. Arun, do you think you would like to come back and finish your presentation, and then we'll quickly move on to questions?
Sure. Sorry for having got disconnected. I think I was on this slide. Am I correct?
We can't see the slide.
Okay, I'll just have to re-share the screen. Yeah, I'm just sharing it. You could see that?
Yes.
Okay, right. So just examples now. We had delayed surgery on cancer patients. I personally had 2 patients who had their neoadjuvant therapy at another center, and they were to be operated in March. They went to those centers, the centers were closed, then they waited. Finally, when they came to me and when we operated, one esophageal cancer patient, the cancer had spread all over and we were not able to do a curative surgery on him, which was very unfortunate. A second patient who had come from Kolkata, luckily his tumor had not spread that much, so we were able to operate. So delayed surgery on cancer patients, the Raman has already given the statistics, has been one of the biggest problems with this pandemic for non-COVID people. Now, gallstone patients, now this is something I have gone across and spoken to surgeons across India. They have been coming with gangrene and perforations, high incidence of pancreatitis, obstructive jaundice. So what this basically means is high cost of treatment, higher morbidity, and a higher incidence of conversion from laparoscopic to open surgery, which used to be less than 1% and now close to 5% patients in this pandemic era, when they come with complications, they end up with open surgery. Morbid obesity patients, the disease has been worsening. People have been gaining weight. Those who are waiting for, surgery for things like diabetes, arthritis, those awaiting renal transplant. Now, these are the patients who have suffered a lot for bariatric surgery. The last line talks about hernia, piles, intestine, and GI complications. Many would say piles. What are piles? Piles are totally avoidable surgery in the pandemic. But just imagine I had a patient who came to me with a hemoglobin of 3. We had to give blood transfusion. So the same surgery that would have required maybe a day's admission ended up with lots of additional things, again, leading to increased cost, morbidity, and mental stress. So the immediate future, I would say, is to proactively manage non-COVID patients who have high-risk conditions. So we look at our waiting list, we look at the people who we've seen in the OPD, and we need to proactively manage these patients. Things like location pooling, cohort wards, separate the last 3 points requires a lot of coordination, and there are many hospitals which are like a chain of hospitals. So in the same city you have got multiple hospitals, so those hospitals need to come together and share the work and divide and rationally allocate staff as well as specialists. Even we need to go one step above, and private institutions across the city need to come together to coordinate between each other, to pool in things like ICU care and various things, even staff if required. Last and not the least, government institutions and private institutions have to work together to jointly get rid of this pandemic and also set an example so that in future, if a situation like this, God forbid, occurs, we are fully prepared for that. And long term, this reclassification of surgery like emergency surgery, urgent elective, semi-urgent, delayed elective, that kind of a classification is needed with resource allocation. And of course, a regular audit of whatever we are doing will help us in replanning things for the future. Thank you very much. Sorry for have got disconnected earlier. I didn't even realize I was disconnected. Back to you, Dr. Subramani.
Thank you so much, Arun. I think, again, a very comprehensive presentation, looking clearly how you dealt with things while you were in the middle of the COVID and sharing your thoughts going forward. Now, we have precisely about 18 minutes, and I would ask each one of you a couple of questions which you can respond together. I would begin with Rajesh. I would like your advice on 3 things which are interrelated. Number 1 was in terms of cardiac outcomes due to delay in elective or semi-urgent cardiac surgeries, number 1. Number 2, post-operative outcomes for semi-urgent or emergency surgery in COVID conditions. And 3, did you have any specific consent forms on high risk for these patients? Rajesh.
Thank you very much, Supra, for these 3 questions which you posed to me. To begin with cardiac surgical outcomes and patients who required surgery really for coronary artery disease. The Society for Cardiothoracic Surgeons and Thoracic Surgeons of UK and Ireland also put out a set of guidelines. Now, the multidisciplinary teams were the main sources of discussion to allocate patients according to the need. The emergency main stem disease were treated by surgery. Their informed consent, which I will come to later on in answering, was done. And the initial experience with stable coronary artery patients and valvular disease was with medical treatment. The cardiac surgeon and the cardiologist worked extremely closely together. And as our experience increased, we realized that going towards performing elective surgery on most of these cardiac surgical patients were attended by the same results as the pre-COVID time. So the elective surgery numbers increased. The answer to your second question about post-operative phase of these patients, in general with COVID patients, the patients who underwent cardiopulmonary bypass took a steep dive. So, if they contracted COVID post-operatively, the outcomes were pretty adverse. So the patients were on the ventilator for a protracted period of time. Patients were treated, effectively because their outcomes prior to COVID was good. So, we had to put them on extracorporeal membrane oxygenators. Patients who came with severe respiratory compromise and damage, which was seen on the CT scans, were even offered lung transplantation. So there was a heterogeneous working pattern, and a lot of decisions were taken with consensus of the group who were around. There wasn't a national consensus on this issue. For your third question about consent, every patient who came to the hospital underwent informed consent, as we do. However, with patients with known COVID and patients who were COVID negative were consented differently. Patients who had a positive COVID were informed that the chances of a recovery depended on their own immune status, because we didn't understand why some people, survived, why some people took a protracted period of time in the hospital, and why some people died very quickly. So in the initial stages, the cytokine storm and the understanding of the cytokine storm, which affected mainly the lung, was not understood. So a blanket informed consent for COVID positive patients were made. Now, for the COVID negative patients, we took all the precautionary measures of making sure that they were completely isolated, and the chances of them getting a positive result later on the 6th or 7th post-operative day was reduced. However, what we could not stop was for some asymptomatic caregiver by way of an intensive care nurse or on the ward when they are transferred back to the ward. So we added a further 5 to 10% on the operative mortality on patients with non-COVID, and they were informed of adverse events in the post-operative phase. You're muted, Subra.
Yeah, thanks. No, I think that just about answers everything. And also, it also clarifies to all of us the value of, categorizing the surgeries into emergency, urgent, non-urgent, and again, those which could be deferred beyond 3 months or elective, as you and I would describe. No, that's a tremendous one. And I'm going to go to Raman at this point in time. Raman, if you had a choice in somebody where you could consider doing a robotic or a laparoscopic surgery and an open surgery, all else being equal, which one would be your choice and why?
So I think this was a question very hotly debated. I think 3 months back, when there were doubts being raised about safety of laparoscopy, and because of the early outcomes coming from different countries, that laparoscopy is not that safe. But I think gradually it was realized that smoke-related issues are not there, and laparoscopy reduces morbidity laparoscopy reduces hospital stay. Laparoscopy or robotic assisted laparoscopy, they are the same. They reduce the hospital stay, they reduce the morbidity, encourages faster patient mobilization, discharge from hospital. And those benefits are substantially multiplied in COVID era, because if you are able to keep patient away from hospital after surgery, the possibility of catching COVID reduces. So I think in my mind, and the person who has been doing only laparoscopy for last 30 years, there is no doubt. And also as the president of the National Laparoscopic Association, I can reinforce that this is based on evidence. And open surgery is only required in situations where laparoscopic skills are not there, or where only open can be done, like a major vascular injuries, and then it's better to go open rather than trying something heroic laparoscopically. So I think there is no conflict in the mind of the surgeon that laparoscopy is a preferred choice.
Thank you, Raman. Now I'll just move on to a quick question to Arun. Arun, during this period of the lockdown, and there is going to be a lot of immobility, there is going to be a lot of people staying at home whose dietary habits may be well beyond what they would like. Do you expect that there is likely to be a higher requirement or a higher need for bariatric surgery in the coming 6 months? Would you unmute yourself, Arun?
Yeah, thank you, Subra. I think in the next 6 months, we are going to see an increase in number of bariatric surgery. One, we've got a backlog of patients who are waiting, whose conditions have actually become worse, because no patient comes forward for bariatric surgery unless they are actually suffering. So the people who have missed out on the surgery in the last few months are going to be there. Plus, I feel that during this lockdown period, because of the diet situation, because of reduced physical activity, a multiplication of our sedentary habits, a lot of borderline patients who would have been otherwise come for surgery much later are also going to come. So I foresee a rebound phenomenon, and this is a problem not just with bariatric surgery but with elective surgery in all specialities, because when the rebound phenomenon comes, we may not be prepared to deal with such a large volume. Even right now, today, Subra, in your hospital, like while Raman was talking, I was getting messages from my secretary that 2 patients who are for these elective surgery tomorrow, we don't have beds for them. So the bed crisis is going to come, resource crisis. So we really need to plan ourselves well for this rebound phenomenon which is going to occur.
No, I think that's very true. I mean, in fact, during this entire week, I think I have had to struggle quite a bit with the beds, both for COVID and non-COVID, with the elective surgeries going up. I think we have really managed to capture the entire complex situation, right from the way the diseases occurred and how very little we knew about it in the beginning, but how we have managed to reach a level of stability and hope to take it forward. I'm sure there could be questions from beyond the panel, but few things that became very evident. I think, Rajesh, when you mentioned our own personal experience in our hospital with the multidisciplinary tumor boards, the structure and the attendance is substantially improved on the MS Teams meeting than physical meetings, number one. Similarly, I find the training of the DNB candidates in several specialities has been more structured and also attended by several consultants who probably might not have managed otherwise during the normal working day. The utilization of the telemedicine. I was quite surprised to learn that even in the United States, the utilization of digital technologies was only up to 15% of what was potentially possible in the practice of medicine. And in the last 6 months, this has really improved substantially. So going forward, with a lot of the digital health technologies coming in, probably bringing in the role of AI in risk stratification, particularly for the non-communicable diseases. And all these, I think, we'll have a tremendous progress as we move ahead. But like all of you pointed out very well in your own comprehensive presentations, it is the protocols, the processes, the partnerships, and above all, being prepared and being proactive is what I think is the true way forward. So I think I would hand over to Malika and to see if there were any specific questions which somebody might want one of you to respond to. But before I do that, let me thank each one of you for such wonderful, such lucid presentations and for being such wonderful partners. Thank you. Malika, over to you.
Thank you.
Nidhi, my colleague, should have received the link of the questions. Nidhi, do we have any questions from the audience?
I forwarded to Mr. Dr. Subramanian. I have done that.
Let me just have a look. Was it on the WhatsApp or?
It's on the chat box here, Dr. Subramanian.
Just
I'll just forward it again.
On the chat box, I don't see questions.
Nidhi, would you like to read them out?
Yeah,
just a bit of time.
Actually, our chat box is not showing. This must be coming on the chat box of the attendees. Our chat box is showing no questions.
That's right, yeah.
So I could, on my phone join the other link and maybe try.
No, this is a unique link that would have gone to the organizer. In this case, my colleague Nidhi. Even I don't have access to that link. So.
Matter. Nidhi, could perhaps just read out the question?
Yes. So if I could read out, it's a question addressed to you, Dr. Subramanian. How do we as physicians decide whether non-COVID or COVID treatment is required or prioritized in patients?
Right. See, I think the decision about something is a COVID or a non-COVID is decided by a simple test. An RT-PCR test will determine if somebody is COVID or non-COVID. Now, deciding on the treatment of non-COVID conditions, as all our previous speakers have so beautifully pointed out, will depend upon the emergency or the urgency of a clinical situation. For instance, something which is a life-saving condition, like if there is a brain hemorrhage or a cesarean section for an advanced pregnancy, or somebody who's got a blockage of a major artery, would obviously need this surgery, notwithstanding whether he or she is a COVID positive patient. The precautions would be different. The outcomes may be a little inferior in COVID positive than in the COVID negative, but these are surgeries which would need to be done in the specially created operating theaters, which are designated theaters with different kind of air handling units or airflows, with complete PPEs, with the proper donning doffing mechanism, with appropriate protection for all the anesthetists. So in terms of the division between the COVID and non-COVID, it's mainly in deciding whether the surgery need to be done immediately at that point or can it be deferred. Something which can be deferred will be deferred at an appropriate point. I know many societies feel that non-urgent and non-emergency surgeries, many of the societies feel that they would prefer to take up these patients about 4 weeks after they were tested as COVID positive. And here I would also like to bring this point which Rajesh made earlier. I think we are all into about 6 months of the COVID, beginning to realize there is a lot of morbidity when people are recovering from the COVID. So the COVID rehabilitation is an extremely important part of the process, and people get evaluated after they have recovered from the COVID We have a structured program for our patients who are leaving the hospital. And based on the assessment in terms of the COVID recovery, plus the urgency of the situation, the surgery is offered. I hope that answers your query. Thank you.
Thank you, Dr. Subramanian. We do not have any further questions from the audience as of now.
We are really grateful because it is 4 o'clock. So let me thank each of our participants. Rajesh, Arun, Raman, thank you so much. I think Mario had to leave because there was a medical emergency which he had to join. But I must say that I thoroughly enjoyed, and it's been such a great learning experience for me, both as a surgeon and as an administrator. Malika, thank you for coordinating the whole activity. Really grateful for all your efforts. Thank the entire organization for this beautiful event. Thank you.
Thank you.
Thank you. Thank you. Bye-bye.
Thank you very much. It was great meeting all of you. And Malika, thank you ever so much for coordinating the show. And I hope we use this platform for further meetings with the College of Surgeons of India. Thank you very much.
Thank you all.
Bye.
Right.
We are live.
Malika?
A very good afternoon to all of you. My name is Arvind Varchistri. I'm the Managing Director of Shri Shri Tattva. I also co-chair the Ayush FICCI committee here. A very warm welcome to all my panelists, and I welcome all the audience to today's webinar, The Science of Ayurveda, being organized by FICCI during its flagship event of FICCI Heal. As an annual healthcare conference, FICCI Heal is being held since 2007, supported by the Ministry of Health and Family Welfare, and recently Niti Aayog, Government of India. The 14th edition of FICCI Heal on the theme Post-COVID Healthcare World, the New Beginning. COVID-19 has impacted the entire world and brought in unprecedented challenges in every aspect, being health, economic, or social. Healthcare being at the epicenter is amongst the worst affections
when we come on panels like this. So, and obviously, healthcare is not untouched by this digital revolution, and the role of digital infrastructure has again vastly increased, be it hospitals adopting to new digital technologies at a very rapid pace thanks to COVID, and that also has had a significant role. And even small clinics and individual doctors are now doing consulting on video calls. And obviously, we are seeing a rise in the medical IoT device penetration, probably a much faster pace. But I mean, the flip side to this is obviously the digital infrastructure today faces a persistent threat of cybersecurity, that leads to a whole lot of challenges, data theft, corruption, business operations being held to ransom, even putting patients, not only patient health, but also patients' life at risk. And again, health sector is no exception to this threat, and in fact, there has been almost an increase of over 150% in cyber attacks during the COVID pandemic, and obviously the Indian healthcare sector in particular is vulnerable due to the low levels of awareness and not so adequate security measures. And the other, I think, new dynamic is obviously the impending policy reforms that are now under discussions and probably will come into play very soon. And that also will have a major impact on how patient data security is managed, how patient data is stored, and how companies will eventually become liable for data breaches as well. So to talk about all of this, we have two experts today with us who have decades of experience in cybersecurity, and they will share their views on what does the health sector need and how do we go about doing it, and what do we do now and potentially what do we have to plan for the future. So we have Mr. Sunil Bangalore, who's the President and CEO of Securix Systems, and my colleague Samir Aksikar, who's Director of CyberWiz. One other thing also is that I'm very happy to share with you that CyberWiz and FICCI are doing a white paper on cybersecurity in the healthcare sector, and I would request Samir to share some of the details on how we intend going about it. And I think this will also be very, very important step, that FICCI is taking. And we request the support of the entire healthcare industry to help us in this as we reach out to you for time, to interact with you. And finally, before I hand over to Samir, I would just like to draw everyone's attention that we have a live poll which has been shared with you. You should probably be seeing it on your interfaces. So I would strongly request all of you to please fill that up because it will help us. And this poll will be live for only 20 minutes. So please do fill in as you get a chance. It's only about 6 questions, so it shouldn't take you too much time. So with this, I'm going to hand it over to the experts. I'm requesting Samir to take over. Samir, can you please step in?
Thank you, Munjal. Okay, so let's dive in into healthcare cybersecurity. Now, understand a predominant audience here is from the healthcare sector, correct? So we have to really understand when we talk about cybersecurity or securing patient care, what do we really mean, correct? Are they related? Is cybersecurity and healthcare related? And this question popped to me as I was building this pack, and I was thinking around healthcare and cyber. And the various analogies the similarities started to pop out to me, correct? And I've put them down here to help you understand some of these. Now, for me, both healthcare and cyber are about healthcare is about securing patient care, and cyber is about securing your organization, correct? It starts from there. A proactive approach towards healthcare is extremely beneficial, as my doctors would always say. And similarly, from an organization perspective, being proactive is better, beneficial, and always cheaper upfront than trying to do something later on when things are all around the place. Doctors regularly advocate a checkup, and in cybersecurity space, it's no different. We would always recommend a regular checkup because the place evolves, cyber evolves so fast, correct? So if there are a couple of things that I would request the healthcare leadership to take away from these sessions. One is, please do a regular checkup of the cybersecurity footprint in your organization. It's absolutely vital, just the way it's vital for our own health to do a regular checkup. Similarly, it's vital even for your organizations. Both healthcare and cybersecurity are plagued by talent shortages. So it's no different in cyber. There are millions of outstanding jobs globally and in India. Similarly, the dearth of talented medical professionals across India is well known. Right? We are all in the midst of a pandemic, extremely rare, as they tell us. But cyber attacks, unfortunately, are evolving at such a fast pace. You're at 1 every 39 seconds, correct? Every 39 seconds, you have a cyber attack taking place in some sectors or another. And healthcare is the one that's been getting a lion's share of it, correct? Obviously, you have so much interesting touch points here from a data perspective. It had to take the lion's share. So obvious question, it won't happen to me. I'm sure that's cropped up in a lot of your minds as I was speaking around it, that won't happen to me. And this is what I tell my doctor as well, won't happen to me, correct? But let's look at what's the reality. So these are the global challenges of cybersecurity in healthcare. I'll just let this sink in. There is not a single region around the world which is not having cybersecurity challenges in healthcare. Each and every region has multiple breaches of health records, of ransomware payments, of penalties by regulators, litigations, and recently, a couple of weeks back, there was the first death attributed to a cyber attack from Germany in Europe. So India is no different. As we ramp up our digitization, correct, we have to ensure that we protect our digital investments in a cyber secure manner. There's one point I'd like to call out on this map. India is the medical devices that we deploy across our organizations continue to leak data online. So that's another point I would request you to take back as leaders in your organization, is when you have governance with your governance meetings with your IT teams, with your security teams, this is a point you want to bring up. Okay. So what happens? So if all these bad things happens, where are we going? So it's a downward circle, it's a downward spiral that I see. Correct. You have financial losses, you have falling share prices impacting the organization, and your reputation is tarnished. So obviously do not want to be in that situation. From a customer perspective, you've lost trust. Data are compromised on your electronic health records. You're in regulatory scrutiny, the regulatory fines, litigations coming up. And then finally, from an organization perspective, again, you've lost, correct? It's a loss of intellectual property, which you may have been doing research. And eventually, at times, closure of your organization because you're unable to address the patients coming in, because your systems are all locked up, as an example, with malware or ransomware that may have been deployed. So it's a vicious circle. And again, if I stop here, I may get a question, so what? All of this is digital with electronic health records and intellectual property. Why is it? It's all digital. I'm not worried about it. But then that's where our national health policy and health infrastructure is going. Correct. You would have heard the recent spate of announcements around our national health policy. Correct. It's a digital health infrastructure. The NDHM, the National Digital Health Mission, is a complete digital health ecosystem. Correct. You have the cybersecurity strategy, which was announced recently by Prime Minister Modi, which would come out in the month of October. That's in a couple of days, it's coming out. You have the India Stack, which is already live. Correct? India Stack is all about your presence-less, paperless, cashless footprint. You have the National Health Stack, which sits on top of it, correct? Which is your fundamental components for health programs across the country. Correct? So, and then coupled with the privacy bill, which is in the works, you have the overall national health infrastructure laid out for you. Okay. So as leadership, as you begin your digitization journey, or you're already on your way, correct, a key question is, how are you securing your digital investments so that you can make leverage, or you can leverage this entire infrastructure and the national health policy which is coming up, or which is already in play now. So it's absolutely critical for you to be proactive in this game. So the question is, okay, how do I go about doing this? Well, there are two ways. There has been the old way, where you would tend to deploy, in portions, firewalls, antiviruses. You'll do some cloud migration. There'll be email security. So a lot of piecemeal-based approach here. And what we're talking about is a change in a systematic way, wherein processes, policies, correct, people, processes, policies, and technology. So very systematic, aligned approach. So as leadership, when you have your governance meetings with your IT or security teams, correct, whether it is for new investments or whether it is for operational aspects, these are the questions you should be asking to say, okay, what investments am I doing from a people perspective, from a people cybersecurity perspective, right? How are my processes being woven into the infrastructure of my organization, right? Do I have policies for third party? Do I have policies for my own supply chain, correct? And what technology am I deploying? Is it integrated across this entire stack? So if this systematic approach helps you align a lot of your thought processes, correct, and move ahead in a consistent manner. So obviously conscious, I'm throwing a lot of stuff at you, correct? This is not your forte, and obviously we need to give you more help to navigate this course, correct? And as Munjal alluded, we are coming up with a securing healthcare knowledge paper. This is something which we're working, which is in the works since with FICCI, and this is the roadmap for it. So the knowledge paper roadmap obviously starts with working with you, as Munjal alluded again, working with your leadership teams to understand the challenges, seek inputs, feedback on what's working, what's not working on the ground. Predominantly focused around security awareness, the knowledge paper. How do you drive that security awareness? What are the policy support you need on the ground? And what are the building blocks really? Mr. Bangalore alluded to me earlier. What's the blueprint? What's the blueprint that organization should follow? Okay. So we take all of this in a cross-pollination, correct? Literally ideating for best practices and ideas, correct, with the teams. And in December is when we plan to release the knowledge paper. There'll be a series of events planned, and they'll be working through with the logistics for it. But this is the roadmap for the knowledge paper. At this point, I will take a break. I'll just remind the audience that there is a poll ongoing, as Munjal said. So it's on your interface. Please do participate in the poll. The questions will help us understand, get an upfront view of what's happening in the environment today. And with that, I will hand it over to Mr. Bangalore. Sunil, over to you.
Thanks, Mr. Samir. I think first of all, it's an honor and a privilege for me to be on with whom I call in my culture, all healthcare professionals have been historically or conventionally in my culture have been referred as gods. We call them Vaidyo Narayano Harihi. So we equate medical professionals and medical fraternity as gods because they play such a critical and probably an essential role in building the entire world. I mean, the human mankind can never be more grateful or gratitude than any other aspect at what we are facing. So good morning, good evening, good afternoon, whichever part of the world you are dialing into this. But when Mr. Munjal and Samir and Shilpa and others talked to me about, can I be part of this? I said, it's a privilege. So I'm trying to do this session with a very conscious aspect of like how doctors explain to me what my disease is. I'm trying to do the same analogy here because I'm pretty sure if I go too deep into my cybersecurity jargons, it's as good as the various jargons that I hear when I go for a health checkup or a health system things. So I've kept it a little bit. Don't take this as I'm treating you all not so conversant with this, but I thought the journey starting point for the whole session has to be at a level that it resonates well with the audience, and maybe we can take it forward as the discussion progresses. And I have offered my help and support in whatever capacity I can to the FICCI system as well. So what I thought, given 12, 13 minutes of my brief time here, I thought, how do we really see cybersecurity as part of the modern healthcare ecosystem that is evolving, and how it can be a key enabler? I mean, if you really look at the whole system of cybersecurity, it is nothing new. I mean, we have all, since human mankind, we have been protecting something or the other which has been valuable to us. Whether it has been anything that we feel valuable, we have been protecting that, which means today data is very valuable asset to us, so we have to protect it. I mean, there is no whims and fancies about it. So it's a key enabler to our digital asset. So what does that mean? Basically, that is, I just thought I'll give you a very broader perspective of how is digitization impacting our healthcare today, right? It's at various scales. Some of them could be 100% digitized. Hopefully, I would like to meet such people, but they may be in the journey. They may have embarked on the journey. So if you look at this, this is pretty crowded. I mean, if I were to talk about this subject 10 years back, I don't think I'd have been able to fill this slide. But today it is kind of omnipresent. I mean, you can talk about the globally dispersed workforce that is contributing to the vaccine development today for pandemic, all the way from medical tourism to telemedicine to personal health information, the diagnostics and imaging patterns, third-party systems that you're trying to integrate, supplier partner. The whole world is a global marketplace for supply chain today. Your insurance payment gateway integration. I don't need to wait in a hospital upon discharge for a couple hours now to get my payment done. It's all instantaneous, like that PhonePe ad, 5 seconds, it gets into the system. So I think it's very irrelevant for me to even remind you that we have entered the digital world. I mean, at what capacity, at what pace, at what instance or maturity level we are in is very individualistic. But in an overall context, I want to set the context that we have started to enter in the digital world, and something getting stolen from us, which is more valuable in this digital world called data, is bound to happen. As Mr. Samir indicated, it's just a matter of when, and it is not if anymore. We cannot think of if I'll ever get hacked. It is just a matter of when I'll get hacked. And that is very critical for this fraternity to know, because if you guys get hacked, my DNA is in with you. All the 23 pairs of chromosome that I studied will be all with you guys, and I'm in trouble, right? Somebody can mutate me. So anyways, so if I move into what are some of the jargons that you hear in the modern world of, oh, somebody got attacked. I thought I'll do, and I know I'm talking to the fraternity, so Grace Anatomy is a very interesting concept. Of all of you would have read the 2,500 page books. So I thought I'll use the anatomy lingo for talking about what is a common cyber attack path. If you really look at the left side, it's a very simple attack. Somebody putting a gun at your head and saying, give me what you have. It's an app which we download on our mobile phones, which we can download on our systems. Our kids start using our systems, then bring your own device. All the corporates have become so smart that they don't want to invest in your laptops. They say you use what you have. So we all start to use our personal systems. Something could get compromised. So there is a network pivotal point where it's a very simple aspect, but it has a lot of impact. But applications can be controlled just like how you allow who comes closer to you. You can manage it. Whereas the right-hand side is a little bit more challenging. This is like your stage 1, 2, 3, 4 of your carcinoma that you keep talking about, how you really move in the stages, right? So if you really look at, there is a first target attack. Attack surface is a user who clicks on something. You won $1 million lottery. I click on the link and boom, I got something. Some keylogger gets installed. Otherwise, there are certain browsing exploiting the browser points. I mean, I leave with this deck. Please, Mr. Munjal, share this with the audience. I would love to have them this deck so that they can internalize it at their leisure. But very important is, if you see the left to right shift, it's very interesting that how the whole system is now looking for vulnerabilities in your environment that we are living in, starting from looting your house all the way through mugging you to completely destroying you. And identity theft could be I remember the Schwarzenegger movie where somebody could be completely eliminated. We have watched it in fictions, but it is bound to happen. So initially, there was a lot of applications for the initial targets. As you see the statistics, about 53% of the breaches were happening on applications. Just because you are careful about not withdrawing money from ATM at night doesn't preclude you from being mugged, because now daylight robbery happens. So now identities are becoming more initial targets. So be very sensitive to the fact that please do not think you're immune or isolated or insulated from the cyber attack. The more cautious you are, like your preventive medication, preventive exercising, all our preventive healthcare is the way to at least save this digital world. So what does that mean to us? We have entered an era of zero trust. I cannot trust anyone. I mean, I was about to wear my mask here in my own office because I don't know who is walking in my office. I mean, right hand doesn't trust the left hand now in this pandemic because we don't know how the contagious formitic transmission is happening probably. So if you really look at the zero trust, it has come in. Those days are gone when the perimeter boundaries were your physical office boundaries or physical buildings, physical cities, physical nations. You don't know who is sniffing on this Zoom call now today from our friends in China. Very important for us is there is a zero trust. When zero trust has entered, this is like the post 9/11, what happens to our air travel. Even presidents and the prime ministers of the world are not frisked, but they also have to go through the digital or the security clearance. So please adopt a very conscious methodology of zero trust. Only when you adopt this zero trust, you will try to lock your doors, windows, and your entry points in a more secure way. Zero trust exists on the network. We don't know where we are having a zero trust on the network. So anonymizing the network elements is a very critical aspect. You don't leak your identity. Like, I mean, I tell you, my most hazardous security point of my individual identity is my cab driver who used to pick me up in those golden days from my airport. He had my name. He knew how I looked at. He had my phone number. Trust me, he knows my house when he drops me. So my entire identity is exposed to my cab driver. So you don't know what you are leaving your footprints on. So on the network, please be very sensitive about anonymizing your network elements. There are various technologies that, as Mr. Samir said, people, process, policies, and technology builds a significant amount of what I call as a protective gear for us. Identity is a very critical element. Don't trust the same cook who walks in your house in the morning. Probably you don't allow her in the midnight if she's coming with someone. Same person, same identity. Don't trust, zero trust. Because we do not know whether your friend has intentional or unintentional issue, but what if his laptop is compromised and you leave a password unchecked on the system? He may be subjected to hack. Device posture. Again, we log into airports, we used to log into various, what we call as things that did not belong to us, we still trusted them. Please don't do that. The practices are like your hygiene practices. The SOP for pandemic, I was told by a great doctor, FRCP, was maintain the posture of hygienity in your system. Same way in a cyber environment, you got to follow certain etiquettes. Last but not the least is your business processes are always checking on, like in one of our major forensic that we did as a cybersecurity forensic, we realized there was a CEO who authorized a payment. So nobody could have been suspected, but we never knew that CEO's email was hacked. So do not assume your business processes are all sanitized and always sanctity level, because somebody could be watching it. So keep sure that your process. So basically, if you see the data as the key jewel of your data as your jewel, there are three stages: protect data at rest, protect data in motion, and protect data in use. Because data has different life cycles. And unless you protect them through its life cycle, you don't know when the pilferage happens. So please keep in mind that we are living in an era of zero trust. I'm sorry, we have to face it because we are the root cause of it. And data has to be protected through its life cycle. What does that mean? There are different layers. I mean, this is in medical field, I don't know how many things can be written, but in a security control perspective, there are distinct levels. This is a science. This is an engineering science. So there is finiteness here. Unlike 7 billion people having 7 billion distinct anatomy, body anatomies probably. This is unlike that. There are distinct finite elements that if we take care, reasonably we are protected. And it depends on what is your criticality. If you think you can be at basic level and you can survive, great, good luck. If you are in proficiency level, good. But if you are in optimized level, you have not only managed your total cost of ownership on such locks that you put in or protection gear, but also you're guaranteed the losses on the right side of Mr. Samir's presentation of not only reputational risk, but also business resiliency risks can be managed. And what are those? Infrastructure is the bottom line. Then comes up on that your set of applications. Then comes the data. Then comes the people. Then comes the fraud. And then comes the intelligence. So if you have listed down, you are in the context of your organizations. You can be a healthcare supplier, you could be a hospital, you could be a financial institution doing insurance, or you could be an individual practitioner, a medical practitioner, or could be a nursing staff. I mean, I know you have different roles, but very important aspect is you need to be able to map the elements of attributes of potential vulnerabilities against what you are trying to accomplish. And this is again like a human psychology. Security, as I said, is no new thing to human mankind. We have been protecting things that matter to us all along, which was valuable to us. It is just that now we enter the digital world and we are protecting the data. So what does it mean? Everything is an evolutionary path. As Darwin once said, which I strongly believe, struggle for existence continues on as long as we are alive, and survival of the fittest happens. There is no second thought about it, which means we have to evolve. But how do you evolve from? First, try to be operational levels. How do you do that? Just try to prevent certain things. Like, as I said, you don't go to ATMs and withdraw cash in the midnight when nobody is around. There are certain fundamental hygiene operational things you got to do. Then you start to detect it. Is somebody coming on a bike? Then you tend to become protective. If somebody is watching you, you become a little bit alert. So prevention is the best, so that you don't go withdraw cash at the ATM on the midnight. But if that is inevitable, then see whether you can at least be sensible enough to be detecting what could be going wrong. If somebody is standing in the closer to ATM and you find him suspicious, you don't enter the ATM. Similarly, in the cyber security, if you get an email coming from an unknown source, don't click on it in enthusiasm. Oh, I won $1 million. Trust me, guys, nothing is free in this world. So I think this is very critical for us to ensure you are alert. This is awareness. Detection is purely based on your alerts and your alert awareness system. Then you start to emerge into a little bit more maturity, where you start to look at how do I respond if somebody were today. Like in the US, when I used to live, they used to carry this pepper spray. A lot of women used to carry pepper spray because they thought that was the easiest, most elegant thing to carry in a women's vanity bag. It didn't cost them much and it didn't hurt them more. So anyway, what I'm trying to articulate here is there is an evolutionary path. A typical adoption, you don't need to be thinking, oh, my neighbor is in the optimized level. How do I succeed in this? Am I in? Even through the journey to Himalaya starts with a single step. So you have a desired end state in your mind. What requires, what is the right sized investment and affordability and availability of skills, but move on a maturity model. And I don't want to go each one of it because I can talk for hours on each one of them. And I see already some people glaring at me. So next slide is, thank you. What I want to leave with you guys in the last 30 seconds is, this is a fascinating place that we are living in. We have moved from where we had to see each other physically and shake hands to where we are today, where I can see Mr. Munjal smiling. I can see Mr. Samir with a grin face. You can see me being very jovial or very rigid. I don't see other audience, but honestly, I'm not telling we can get away from that, what we call as the physical level of interaction, but there is another way to live in this digital world. As long as we follow that hygiene of how do we live in the digital world with some fundamentals that we understand and embark on a journey of securing what we believe is a valuable protection, I think we have got a reasonable level of accomplishment in the survival mode of digital world. And good luck to all of you. I hope all of you will start your journey now, if not already started, which I know many of you are at different inflection points. And again, I would like to sincerely thank FICCI for giving me an opportunity to briskly walk through whatever my little few experiential learning has been. Over to you, Mr. Munjal.
Thank you, Mr. Bangalore. I think that was quite good. And thanks, Samir, as well. I think one key takeaway from this, obviously, is the fact that we need to inculcate a culture of cybersecurity. I think that's the key today, that how do we start thinking on those lines? And unfortunately, right now, we are not thinking on those lines, And the other factor is also that you may have the best of systems, best of technology, but it is the human factor in all these which is very critical. At the end of the day, data breaches eventually happen due to human error, and it happens to the best of organizations. And I think the only way to deal with it is to build a culture, which is essentially build a culture of, that being aware about where the data is being generated, where the data is being stored, like Mr. Bangalore's slide on data in motion, Data is constantly in motion, and you need to secure it at every juncture. The other thing is also that I think one of the biggest problem is that a lot of people have a head in the sand approach to security. Oh, it's too expensive. So let me not go there. I think there are some very interesting models that are emerging, and one of the critical things is also something called as a VCISO, which is a virtual Chief Information Security Officer, and these services are available, and people can avail of these services. And they can help you, particularly for medium to small enterprises and hospitals or clinics. You can avail of these services, and you can help them, or rather, they can actually even help you write a policy, which is a manual for managing a cybersecurity incident. So when your system is, if you're hacked, or if there's a ransom attack on your clinic, what do? You should have the ability to eventually, format your machines and be able to get up and running in a couple of hours. You can only do provided you have done adequate backups, you have put those policies in place, you have also actually ensured that you have tested them out, which is actually attack and see what has actually happened. I mean, these are things that you need to do. And again, I think these are all things that need to be done. It ultimately boils down to having a culture. If you have a culture of cybersecurity in your organization, I think it all, if you look at the whole information technology age, I think when we started out with computers where every day morning we used to come into the office and people used to light a lamp and agarbatti in front of the computer and start using the computer. I think from that today we've become fairly savvy and people are using computers, walking around with them. The mobile phones that we use today are far more powerful than the desktops of that age. So we've seen this evolution of technology happen in the last 20-25 years. So I think this can be actively be managed. And I think the white paper, what Samir spoke about, is again something that I think will help trigger some of, at least we're hoping it will help trigger the key conversations within the industry and also within your organizations. I'm just going to now take a pause here and just share the results of the poll. So here are the questions. The first question is that, do you have any independent end-to-end cyber healthcare checkup of your healthcare institution done over the past 1 year? So out of the people responded, 20% said yes, 80% said no. So that itself gives us a kind of an indication as to that 80% of the organizations really need to start thinking about it. The other question is that, is the current IT budget allocated to cybersecurity at least 5%? And 20% are saying yes, it is, and the others are saying no. The third question was, does your organization possess and maintain a full inventory of all your devices on your hospital network? And I think here, at least I'm quite happy with the number that 40% are saying yes, they do have a full inventory, which is great. I think that's a great first step, And the fourth question was, does your organization have a cyber security awareness program on a recurring frequency? And here the answer is a flat 0. Nobody does this. And this is exactly what I was alluding to earlier. I was talking about that awareness or culture of awareness needs to set in, And finally, the thing is, the last question was that we had asked is that, did any cybersecurity incident or IT issue cause hindrance in normal operations? And that's a staggering 60%, So in some form or the other, organizations have been impacted by this incident, whether it's a virus attack, whether it's a ransomware attack, or any such incident, or basically in some form or fashion, your normal operations are impacted, and that has a direct bearing on your patient, and I think that is something that we need to look at it very, very seriously. So with this, I'm going to now open up the floor for questions, and I'm just going to see if we have any questions here. Do we have any questions so far? So we're not seeing any questions. Okay, so I think then maybe we can close this session because we've already overshot in terms of our time allocated to us. So any closing comments, Mr. Bangalore and Mr. Samir, and then we can close the session.
Samir?
I think I'm good. I would just reiterate, please take a proactive approach towards your health as well as cybersecurity. Thank you.
And I must probably echo that, but I will add one more thing. Also take care of your, in my opinion, setting aside right priority for both of them. It's very important you prioritize them because, as I said, when it happens, it will be a catastrophic failure sometimes. So there won't be a second chance. Please take care of it. Good luck and all the best.
So with that, I would now want to close this session. Thank you all so much for coming here and being a part of this, and very happy to see the people participating in the poll. And I think this is a first step. This itself gives us some insight into where we are and what we need to do. So thanks a lot. Thank you so much to both the speakers. Thanks a lot again. And thank you, FICCI, for organizing this. And with that, we'll say goodbye to you all. And I think we can wait for the next session to start. Over to the FICCI team.
Thank you.